Hello, everyone, and welcome to another edition of URO-GRIPP. It is a great pleasure for me to welcome you in this last edition of the first round of URO-GRIPP. It's a great pleasure for me to welcome all our speakers and to all the audience. As Mahatma Gandhi said, the future depends on what you do today. And today we are going to shed some light on bladder cancer. So this is our last module for the year, which will culminate with bladder cancer. And once again, I'm really thankful from iTRUE, which is International Training and Research in Uro-Oncology and Endourology, and welcome you to the Urology Global Resident iTRUE postgraduate program. With me, the program directors, Bhavan Rai, who is also the Vice President of iTRUE, and Zishan Hamid, who is the Secretary of iTRUE, and Bhavan and Zishan are going to be the conveners of this program today. I have got a very good lineup with some very experienced and some budding speakers, and you will meet them all through some pre-recorded and live sessions, and I can't wait to hear it. The program schedule would be as follows, and to take it forward, I will be passing it on to Bhavan Rai shortly. Just to also remind all the viewers, this is our 12th, or the last of the URO-GRIPP, the first version. The second URO-GRIPP modules will start from next month, and the 28th of August is going to be the first module, which will be on prostate cancer. So with that, thank you everyone once again for joining, and it's my pleasure to hand you over to my colleague, friend, Bhavan. Bhavan, over to you.
Thank you very much, Bhaskar. Welcome to everybody for this session on bladder cancer. As Bhaskar said, this is the last webinar of this URO-GRIPP series, and we've tried to encapsulate some of the most important topics in bladder cancer. Please be reassured that when we have a new series, we'll be having some more sessions on bladder cancer. We appreciate that this is quite a big topic. So in the interest of time, we've only addressed some of the more important topics in this session today. Our first speaker today will be Sarika Nalagatla. She'll be speaking on how we should be investigating hematuria and some of the more contemporary and perhaps some of the more older evidence that's advised our practice. Sarika is a specialist training in urology in Glasgow. She also is an executive member of the British Society of Trainees in Uro-Oncology, and she also represents them in the bowels oncology section. So without further ado, I'd like to ask for her presentation to be started.
Hello, my name is Sarika Nalagatla and I'm a Urology Specialist Registrar in the west of Scotland. Today I'll be talking to you about how to investigate hematuria and what is the evidence behind this. Hematuria can be grouped into three categories. Visible hematuria, formerly known as macroscopic or gross hematuria, is blood that is visible in the urine, colouring it pink, red or dark brown. Non-visible hematuria, formerly known as microscopic or dipstick positive hematuria, is blood that is present on urinalysis, but it's not visible. Non-visible hematuria can also be defined as the presence of 3 or more red blood cells per high power field on a midstream clean cat urine sample, and that's under microscopy. The sensitivity of urine dipstick of a freshly voided urine sample is now good enough for detecting hematuria that routine microscopy is often no longer considered necessary. Dipstick hematuria is considered significant if there is 1+ or more on the urine dipstick. Trace hematuria is considered negative. Non-visible hematuria can further be categorized into symptomatic and asymptomatics. Those with symptomatic may experience symptoms such as suprapubic pain or symptoms associated with renal colic on a background of non-visible hematuria. Pseudohematuria presents as red or brown urine that is not secondary to the presence of hemoglobin. Causes can include medications such as rifampicin, hyperbilirubinemia, or certain foods such as beetroot or rhubarb. There are several causes of hematuria, and these can be grouped into urological cancers, stones anywhere in the urinary tract, infection, inflammation, trauma to the urinary tract, renal cystic disease, renal papillary necrosis, underlying vascular disease, benign conditions such as BPH, nephrological conditions, and coagulation disorders. And today we'll be focusing on the underlying urological cancers. So what percentage of patients with hematuria have urological cancers? A study by Kadra et al. Described this as 20 to 25% in those presenting with visible hematuria and 5 to 10% with those presenting in non-visible hematuria. I'll later go on to talk a bit more about this study in this talk. Further figures come from the study by Edward et al., where their study describes bladder cancer rate in patients referred with visible hematuria as 18.9%, but only 4.8% in those referred with non-visible hematuria. Less than 1% of patients referred to the secondary care with hematuria had also had upper tract TCC. The IDENTIFY study, which was published in 2021, demonstrated that bladder cancer was the most common cancer with an adjusted prevalence of 24.7% with hematuria. The rarer upper tract cancers, upper tract urothelial cancer, and renal cell carcinoma accounted for only 1% each. These figures highlight that the presence of red blood cells in urine can be perfectly normal finding, and explains why approximately 70% of patients with microscopic or dipstick hematuria, there's no abnormality found despite all conventional investigations being undergone. There are several risk factors associated with urinary tract malignancy. The ones I want to stress upon is increasing age, being male, having an underlying smoking history or being a current smoker, and those presenting more with visible hematuria than non-visible hematuria. Of note, the study by Edward et al. Demonstrated that in men aged less than 50 years with non-visible hematuria, the chance of finding malignancy was low, and overall this was comparable to women less than 60 years presenting with non-visible hematuria. In the case of visible hematuria in these age groups, the incidence of malignancy increased. There was more marked increase in the detection rates of malignancy above these age thresholds, with 1 in 10 chance of detecting malignancy in patients with visible hematuria and 1 in 30 in those presenting with non-visible hematuria. No upper tract tumours were detected in these patients aged less than 30, and no upper tract TCC was detected in those aged less than 50. The prevalence amongst men was twice that amongst women. Their data supported the rationale that patients aged less than 30 could potentially be investigated initially by nephrologists as the risk of urological disease was low. The IDENTIFY study, published in 2021, showed that patients with visible hematuria had an overall cancer prevalence of 26% compared to 6% presenting with non-visible hematuria. Irrespective of the type of hematuria, the proportion of cancer appeared to increase with age, those with a smoking history, and being male. In patients with non-visible hematuria, there were no cancers in the under 35 age group. In patients with visible hematuria, the overall cancer prevalence was 17.8% in never smokers versus 35% in current smokers. Visible hematuria, older age, male, and smoking were all shown to be significant risk factors for all urological cancers. Compared to patients who have never smoked, ex-smokers and current smokers had significantly increased odds of developing bladder cancer and upper tract urothelial cancer, with current smokers having more than a 3-fold increase in the odds of bladder cancer. International guidelines for suspected cancer referral pathways vary greatly. Established risk factors are not always featured in referral criteria. The UK NICE and AUA guidelines differ. Both give different age thresholds for recommended investigation of each type of hematuria, and we'll discuss this very shortly. There are several investigations that a patient can undergo for investigating hematuria. The diagram here is taken from the IDENTIFY study, which was published in 2020. And here it shows how patients can be typically referred and investigations they could undergo. So in the primary care setting, if you're presenting with head-bank hematuria, you're often then referred on for a urological assessment where you undergo focused urological history, examination, and undergo a cystoscopy, which is the gold standard for diagnosing bladder cancer. And you often undergo further imaging to assess whether upper tracts for malignancy or benign causes of hematuria such as stones. The identified studies showed that 95.5% of all malignancies and 95% of all pathology were diagnosed following an abnormal flexible cystoscopy and or ultrasound alone. 1 renal malignancy and 4 upper tract TCCs that were diagnosed with a second-line investigation had an abnormal ultrasound. So this shows how important a combination of having a flexible cystoscopy as well as upper tract imaging is important. The UK NICE guidelines published in 2015 and updated recently in 2021 give advice for the urgent referral of an adult to urological services for specialist hematuria investigations. They suggest that those aged 45 or over who have unexplained visible hematuria without a urinary tract infection or have visible hematuria that persists or recurs following successful treatment of a UTI should be referred. They also suggest that those aged 60 who have unexplained non-visible hematuria and either dysuria or a raised white cell count on their blood test should also be referred. They also suggest those that are asymptomatic but have persistent non-visible hematuria should also be referred. They also give guidelines as to who should be referred to the nephrology team. The AUA guidelines differ from the NICE guidelines in that they advise that all patients with visible hematuria and patients with non-visible hematuria over the age of 35 should be investigated. They also require formal microscopic evaluation of urine and not just a positive urine dipstick. Those that have non-visible hematuria are risk stratified, and they also give specific urothelial cancer risk factors for this. This is the EU algorithm for investigation of microscopic or non-visible hematuria. As you can see, the patients are categorized as low, intermediate, or high risk. In patients with low risk malignancy, AUA advises that the clinician should have a discussion with the patient to decide whether they should undergo a repeat urinalysis within 6 months or proceed with a cystoscopy and renal ultrasound. In the intermediate risk group, clinicians should perform a cystoscopy and renal ultrasound. In the high risk group, they should undergo a cystoscopy and a CT urogram. No urinary markers, including a urine cytology, should be used in the initial evaluation of patients with microscopic hematuria. Urine cytology is advised to be obtained for patients presenting with persistent microscopic hematuria after a negative workup who also have irritative whiting symptoms or risk factors for carcinoma in situ. In patients with a negative workup, clinicians may obtain a repeat urinalysis within 12 months. The patients with a prior negative workup and a subsequent negative urinalysis, they may be then discontinued for further evaluation. If, however, the repeat urinalysis is positive for microscopic hematuria, the clinician should then discuss with the patient whether to observe or re-evaluate in the form of further imaging. The first paper by Kandra et al. Is one of 4 papers that are important when looking at the evidence as to how we investigate hematuria. Kandra et al. Published a paper in 2000, and their main objective was to ascertain whether a less intensive algorithm could be adopted for investigating hematuria whilst remaining diagnostic efficiency. So all of their patients in their study group underwent an abdominal radiography, a renal ultrasound, an IVP, which is an intravenous pyelogram, and a flexible cystoscopy. One of the most important findings from the study showed that kidney and upper tract tumours were noted in 14 patients, including 4 who presented with microscopic hematuria. And if only an ultrasound or IVP had been performed, then 4 of these cases could have been potentially missed. So they concluded that a cystoscopy cannot be safely avoided in the younger patient group with microscopic hematuria, and that only a combination of an ultrasound scan and IVP should be used in detecting upper tract cancers. The next study by Edwards et al. Looked as to ascertain the merits of using an ultrasound scan, an IVU, or both when imaging the upper tract. They prospectively looked at a two-tier protocol when looking at patients presenting to the hematuria clinic. All patients underwent an ultrasound scan and a flexible cystoscopy as their first-line investigations. An IVU was only used following an abnormal first-line test and those presenting with persistent hematuria where no abnormality was detected. The results from this study show that ultrasound scans are an effective way of detecting upper tract tumours, although better for RCC than upper tract TCC. This highlighted the use of interval testing as a good pragmatic solution, given that most cases of upper tract TCC show persistent hematuria and that ultrasound alone is a highly sensitive test for RCC where persistent hematuria is less reliable. The study did not use urine cytology as a first-line test, in contrast to other published material. They explained that urine cytology in this context, despite being highly specific, has an established sensitivity of 25 to 40%. Some of the conclusions and recommendations from this study show that an ultrasound scan should be the first-line test as it is effective, cheap, adequately sensitive, avoids unnecessary radiation exposure, is appropriate to use in pregnancy, and allows rational use of CT and IVU investigations, which constitute a significant risk after radiation exposure to the individual. Given the sensitivity of ultrasound for diagnosing RCC, the use of additional upper tract imaging should be limited to identifying undiagnosed upper tract TCC. Although, as with bladder cancer TCC, there is no evidence that tumours detected at this presumed earlier junction are more amenable to treatment than those presenting via other routes. Based on their current findings, they recommended that an IVU should be confined to men aged 50 or older with macroscopic hematuria and positive repeat dipstick urine where first-line tests are negative. The DETECT study published in 2018 was a prospective multi-centre observational study. All of their patient group underwent a cystoscopy and upper tract imaging, and they addressed the question as to whether age at presentation can be applied as a threshold for referral for hematuria investigation. One of their key findings was that of the bladder cancers diagnosed following non-visible hematuria, 59% were high-risk cancers, with 31% being muscle invasive. They also looked at the NICE and AAU guidelines, and this showed that although the risk of urinary tract malignancy in non-visible hematuria is low, clinically significant cancers were detected below the age threshold for referral for investigations. So, application of the NICE guidelines defined age threshold failed to detect 10.5% of cancers presenting with non-visible hematuria and 2.2% of cancers presenting with visible hematuria. So they recommended that patients with visible hematuria should be investigated regardless of age, and that a more international consensus of how patients should be referred for investigation of hematuria needed to be addressed. The IDENTIFY study published in 2021 was an international multi-centre prospective observational study conducted by the BURST Collaborative Group. It looked to evaluate the contemporary prevalence of urinary tract cancers in patients referred to the secondary care setting with hematuria, and this was adjusted for established patient risk markers and geographical variation. One of the interesting results from the study were the odds ratios for the patient risk markers. Age, visible hematuria, males, and smoking all had an odd ratio of greater than 1. There was also no cancers found in the non-visible hematuria group in patients aged 35 years old for bladder cancers or under 60-year-olds for upper tract urothelial cancer. This was the first study to report urinary tract cancer prevalence across an international population in patients referred to the secondary care, which was adjusted for patient risk markers and geographical variation. They showed also that bladder cancer was the most prevalent disease and visible hematuria was the strongest predictor of urinary tract cancer. So far, we have looked at the different types of investigations performed for hematuria and the underlying evidence for this. However, there are some implications of over-investigation. Firstly, cystoscopies can cause discomfort and can carry risks such as infection and bleeding. Radiation from CTs have been shown to be associated with secondary malignancies. Patients having equivocal results can result in them having further invasive testing, such as biopsies under a general anaesthetic, to confirm a negative finding. A large proportion of patients investigated, therefore, may have unnecessary invasive procedures. The annual cost of these investigations are significant. In the UK, patients' normal results from hematuria investigations cost the NHS £33.5 million annually. And this goes to show why it is important to tailor investigations to patients. So to summarise, cancer risk factors and patient characteristics should be taken into account when investigating hematuria patients. From looking at the guidelines we've discussed today from NICE and AUA, there is a variation in how patients are referred and investigated. Patient counselling and shared decision making is key in investigating hematuria patients appropriately. These are my references from the talk, and thank you very much for having me today.
Thank you very much, Sarika. That was an excellent talk summarizing some of the key issues with investigating patients for hematuria. I'd like to now invite Nikita Bhatt, who will give us a presentation on how to perform a good quality TURBT. Nikita is a specialist registrar in Norwich. She's also currently the vice chair of BURST, which is the research wing for trainees in British urology. Nikita, if I can ask you to take over, please. Thank you.
Thank you. Thanks, first of all, for having me today. Just going to share my screen. Okay, so can you see that? Is that all right? Good.
Yes, we can.
Great, thanks. So I'm going to talk about performing a good quality TURBT. I think TURBT is one of those procedures that we do in urology as a core procedure that definitely affects outcomes in patients, and the quality of this procedure especially tends to affect how patients will do during the course of their cancer treatment. This has been summarized in all the guidelines that TURBT is an essential step in the management of non-muscle invasive bladder cancer. You perform a proper TURBT by pathology investigation as a diagnostic procedure and an initial treatment step. I was watching one of the webinars from UCSF recently, and I really like this slide from there, which I've put here. If TURBT was invented in this era, they'd probably describe this as something like a focal, targeted, personalized, single port, natural orifice, scope, no scalpel, minimally invasive technique to treat non-muscle invasive bladder cancer. And hence it should be done well when you're investigating your patients at the beginning of their journey. So I'm going to go briefly through the steps of TURBT and then talk about our study Re-Resect that really deals with the quality of TURBT towards the end. So the steps of a TURBT include a bimanual palpation under anesthesia, which is really important and quite often forgotten step when you're starting off the procedure. Then it involves insertion of a resectoscope, visual inspection of the entire urethra, inspection of the urothelial lining of the bladder, if indicated, the biopsy of a prosthetic urethra, which I'll go through, cold cup bladder biopsy if indicated. Then you resect your tumor, you record your findings in your op note, and you ensure that you have a precise description of the specimen for path evaluation. So I'm going to go through all these steps in detail now. There's now growing evidence, and it's involved in the guidelines, that we should try and use adjuncts with white light TURBT. And the options available at the moment include PDD, which is instilled into the bladder about an hour before the procedure. This is absorbed as a hexaamino-level unit, and it's converted into protoporphyrin 9 and shows up as red fluorescence on illumination with the blue-violet light, and as you can see in the pictures here. And the other thing that we can use is narrowband imaging, which uses blue and green spectrum of light to improve the visualization of flat areas in the bladder that may not be otherwise that obvious on white light. There is evidence to show that PDD has improved sensitivity at both patient level and biopsy level. However, it does have a lower specificity. It has also been shown to lower recurrence in both short-term and long-term. However, at the current moment, we don't know the effect on progression and mortality. Resection type originally used to be piecemeal is what we were doing, but there's now growing evidence about en-bloc dissection, and this includes using either monopolar, bipolar, or laser in select exophytic tumors, as you can see here, to resect the entire tumor en bloc. There is evidence to say that with this sort of a technique, you can get high quality specimen and you can achieve Detrusor in about 96 to 100%, which, as I'll come to on the next slide, is quite important. Bipolar resection has been introduced, and there is some theory that it can reduce complications such as bladder perforation due to obturator nerve stimulation, but this is controversial. Certainly increasingly in the centers I've worked in, we've started using bipolar resection. Again, to avoid cauterization of the base, to ensure that you've achieved good muscle from the base before you do that. And the guidelines would also suggest that for small papillary recurrences, outpatient fulguration or laser vaporization is equally safe as resecting them, especially in elderly or comorbid patients. So Detrusor muscle, I'm sure everyone is aware of this, and something that's been really driven home by all guidelines is to obtain Detrusor during TURBT. And why do we do this? It is because if there is no muscle in the specimen, you're at a high risk of residual disease, early recurrence, and tumor understaging. There's a lot of evidence for this. For example, when Detrusor is present, the residual tumor rate is about 20%, but when absent, it's nearly 51%, and this is really significant. Biopsies, usually you try and take biopsies from red patches or abnormal looking urothelium around the tumor. Mapping biopsies you can take if the cytology is positive and the cystoscopy is normal. Increasingly, however, with PDD, you can see these areas quite well, so the mapping biopsy role has reduced. Prosthetic urethral biopsies, again, for things like bladder neck tumors, suspected CIS, if there's a positive cytology or there's abnormalities in the prosthetic urethra that are visible. And the way this is done is you go at 5 and 7 o'clock in the precollicular area and use a resection loop to take these biopsies. And the reason is about 40% of patients with prosthetic urethral involvement will have this an invasive disease, and this can be easily missed. And it is an important predictor of invasive disease, especially if there is a stromal involvement in the prosthetic urethral biopsy. This tends to upgrade the tumor from a non-muscle invasive. And then the next step is documentation. This is also key and has been emphasized in all the guidelines. There are certain things that need to be there on your op note when you're doing a TURBT, and these include the size and number of tumors, the adequacy of resection, whether you've achieved a visually complete resection, have you seen muscle at the resection base, presence of complications, especially if there's a perforation, and then you try and measure the tumor size. The way you do this is the use of your end of your cutting loop is approximately 1 centimeter, so you use that as a reference. Then you describe what was the nature of the tumor, sessile, nodular, papillary, or flat, and if they've had any previous treatments such as intravesical treatments or radiotherapy. Again, similar things you want looking for in a pathology report in your MDT are tumor location, tumor grade, stage, lymphovascular invasion, unusual histology, presence of CIS and detrusor muscle, which will all impact how you decide the risk category of this tumor. So all of these are important to be documented in the op note and the path report. Re-resection, again, it's something that is quite evidence-based. The first evidence for re-resection came from her, who works in Memorial Sloan Kettering in 1999 in the Journal of Urology. Since then, there have been a number of studies showing why this is important. So the guidelines would suggest that you perform a second TURBT after you've had an incomplete initial TURBT, or you're in doubt that you haven't completed the resection, or if there is no detrusor in the specimen, except in low-risk tumors and primary CIS, and in all T1 tumors. You ideally perform it 2 to 6 weeks later, and you try and resect the primary tumor site. And in the pathology report, you mention it's a re-resection. So a recent systematic review with over 8,000 patients showed that there was 50% risk of persistence with TA or T1 high-grade tumors, and 8% risk of understaging in T1 tumors. So this is clearly an important step in TURBT. And then the last step as you're completing your TURBT is to think about whether you want to give intravesical treatment or not. Intravesical treatment is usually in the UK, we've been giving mitomycin. You can also give epirubicin. You try and achieve this sort of intravesical treatment within 6 hours of your primary resection, and this has shown to reduce your 5-year recurrence rate by 14%. From 59 to 45%. There's some growing evidence about gemcitabine, but the results are quite mixed. So who should receive this is for intermediate or risk or primary tumors with a recurrence rate of less than 1 recurrence per year, or an EORTC recurrence score of less than 5. You can also give this for presumed low-risk tumors and small papillary recurrences over 1 year after their previous TURBT. Giving intravesical treatment will impact on the recurrence even with further adjuvant chemotherapy installations, for example, BCG. So this is important, especially if you think that your tumor is low risk or intermediate risk at your original resection. This will also, the theory is that the intravesical treatment reduces implantation of tumor cells after your BT. To achieve improved compliance with intravesical treatment, we try and give this during the resection itself. So immediately post-operatively in theatre, it's given by the surgeon, because there is some evidence to show that if you leave it to the nurses in recovery, for example, or on the ward, the compliance is lower. So if you look at all the evidence on TURBT, there is growing evidence that despite all our best efforts, whether re-resection or intravesical treatment, there is a lot of variability in bladder cancer treatment. So there's something else going on. And Brozzi did this study in 2002 who said that there's a lot of variation in the recurrence risk after the first cystoscopy, So clearly there is more than just giving intravesical treatment or following guidelines. Mariappan in 2012 found that TURBT surgical quality makes a huge difference. So there's a lot of variation, for example, in the Scotland quality indicator study that showed that if you achieve a lot of variation in detrusor presence or absence or giving intravesical treatment, the quality of TURBT was extremely variable. So they did a study in Scotland over 2014 to 2017 to show that the recurrence rate was different based on the TURBT quality. And even telling people that their quality of TURBT was different or wasn't up to speed changed the recurrence risk, which is why there has now currently been a lot of focus on improving TURBT quality. It has been recently called as the neglected procedure in the technology race in bladder cancer. There's a lot of energy and focus now on improving TURBT quality, reducing variation in practice so that the recurrence risk at the first cystoscopy is at least comparable across different centers. With this in mind, Burst is launching Resect, or we've already launched it, and it's currently recruiting patients. So Resect is to determine if audit and feedback can improve the quality of TURBT surgery and reduce early recurrence. What we are trying to do is launching audit and feedback into the digital age. To take part in this study, you need to be a center that performs TURBT for non-muscle invasive bladder cancer and submit only 25 prospective and retrospective cases over the course of a year. You recruit consecutive patients undergoing curative treatment. You register your study and you start retrospective collection first. You enter data about TURBTs performed before the start of the study. We will then give you feedback on how your centers are doing, very similar to the QPI data. And then we will ask you to collect prospective data after you've received this feedback to see if whatever feedback we are giving you is improving your performance. And then we'll follow up the data about the re-TUR, first check follow-up, and at the moment we're only following it up for less than 6 months. The primary outcome is we're trying to see if people are achieving key TURBT quality indicators, which we will make clear at the feedback stage. And the secondary outcome is early recurrence rate at less than 6 months. Again, it's only 25 studies, out of which only 20 need to be new tumors, and you can have a minimum of 3 authors with this sort of authorship requirement. You can include more authors, and by collecting 10 more patients in each retrospective and prospective phase. So this is essentially what we wanted to build as a tool for you and your team to see how you're doing compared to different centers in the world. So we've got international recruitment, again, such as Identify, all around the world. All your data will be anonymized. You can look at your data filters live as you go along and try and improve the quality of TURBT if necessary. So it is based with REDCap. So all you need to do is first ensure you've got ethics, then you collect the TURBTs, identify the cases from the previous 6 months, you screen them, enter them on REDCap, we give you feedback, and in the end you identify deficiencies and improve. So we've already launched this study, but if you haven't taken part and you would still like to get involved, you can email us on this email ID. And yeah, participate. Thanks very much, and thank you for inviting me to talk.
Thank you very much, Nikita. That was an excellent talk on the quality on TURBT. And we look forward to the results of Resect in due course. I'd like to now ask Jeremy Teo from Hong Kong to deliver his talk on en-bloc techniques in bladder cancer. Jeremy.
Hi, my name is Jeremy Teo from the Chinese University of Hong Kong. First of all, thank you very much for the invitation. It is my great pleasure to talk about the en-bloc techniques in bladder cancer. A bit of history. Conventional TURBT was first introduced back in 1926. It is a minimally invasive procedure and is the current gold standard for the diagnosis and initial treatment of bladder cancer. But what we observe is that the cancer control of non-muscle invasive bladder cancer is quite unsatisfactory. 1-year recurrence rate ranging from 15 to 61%, 5-year recurrence rate up to 78%. Therefore, there are many different adjunct treatments that we can consider in order to optimize the cancer control. And most of the time, patients will need repeated cystoscopy in order to detect any disease recurrence. So I always try to think, are there any problems with the conventional approach? First of all, the first main issue is that during resection, we resect the tumor in a top-down approach, piecemeal manner. It's actually quite difficult to ascertain a complete tumor resection, and it's highly dependent on the surgeon's experience. And because these specimens are fragmented, it's basically impossible to assess margin. Therefore, it is really difficult to ensure a complete resection just by histology. Secondly, during the procedure, when we resect the tumor in piecemeal manner, there will be a lot of floating tumor cells within the bladder. There's always a theoretical risk of seeding of these tumor cells back to the bladder wall, leading to early disease recurrence. Back in 1980, Ombre Resection has been proposed as an alternative technique in resecting the tumor. By resecting the tumor in one piece, we try to avoid fragmentation, minimizing chance of reimplantation, and the specimen remains intact for a proper histologic assessment. Therefore, any complete resection can be ensured by the presence of a clear resection margin. For those who did not have any experience in doing ombre resection, just a simple video showing the principles in doing ombre resection. Small tumor of the left lateral wall. First of all, I will mark the intended incision circumferentially, about 5 millimeters from the visible tumor edge. I will use the coagulation mode to mark this margin, which will aid the subsequent incision. During the procedure, we'll try to keep the bladder slightly distended because this will really aid your subsequent incision. And once you have prepared the margins, then we'll proceed with the incision. Usually we start with the margin nearest to you, the distal margin, and then we incise it with an intermittent burst technique. And then because the bladder is slightly distended, you can see that the mucosa actually will tear apart as you tap on the pedal. And you can actually use the resection lobe to push the tissue, soft tissue, mobile tissue. These are the mucosa and the submucosa. The crossing fibers below, these are the muscle. These are usually more fixed to the resection bed. And I usually use the insulated part, the yellow part here, to push against the tumor to avoid injuring the specimen inadvertently and preserving the specimen for a good histological assessment. Once you have incised the margin circumferentially, you can see that the tumor will shrink into the middle. And then subsequently, you can try to deal with the central part, either with an antegrade or retrograde approach. You can see that I'm trying to manipulate using the resection lobe. Say I'm pushing the tumor, therefore I can see where the attachment below is, and then proceed with the excision here. If you are able to do it properly, you should end up with a good specimen like this. So basically, I would try to pin the mucosa against the foam board so that it's well oriented. The pathologist will know about the orientation, and then he or she can prepare the margins by inking it with different colors, and then the different blocks can be prepared, and usually we'll end up with a good histological assessment like this one. So one of the questions that has been frequently asked is how applicable and generalizable is ombre resection in our real-life practice. Hugh and I actually published a paper on this. We try to implement ombre resection as a primary treatment routinely in our clinical practice. And we focus on non-muscle invasive bladder cancer because this is really what this technique is really intended to cure. In patients with muscle invasive disease, any endoscopic procedure cannot really ensure a complete resection. These patients will need radical treatment anyway. So in this particular paper, we focus on those patients who are having non-muscle invasive bladder cancer. So basically, we looked into 164 patients who tried to implement ombre resection routinely. We were able to do ombre resection in 99 patients. Subsequently, there are some patients who had muscle invasive bladder cancer, so they're excluded because even if we do TURBT, it's not definitive treatment. We exclude the patient who requires cystectomy, and at the end of the day, we still have about 36 patients who are unable to undergo ombre resection because of technical issues and underwent TURBT in a conventional manner. And basically, if we stratify by the tumor size, we found that the success rate is quite high, more than 90% when the tumor size is really small. But say if it is less than 3 centimeters, then the success rate of ombre resection is about 84%. Unfortunately, when the tumor size is more than 3%, the chance of a successful ombre resection is just near 30%. Most of the time, you can still excise the tumor in one piece, but the problem is you may not be able to take it out in one piece. You may need to take it out in multiple pieces, therefore making ombre resection not feasible. And we do multivariate analysis. Tumor size is obviously the major factor that is associated with failure of ombre resection. But I hope that we can try to think a bit more about this issue. Large bladder tumors, when we cannot do ombre resection, is really a big limitation. In my opinion, a few things that we need to consider. Number one, large bladder tumors, more than 3 centimeters. These are the tumors which are actually more likely to be muscle-invasive bladder cancer. So even if we can do ombre resection, these patients will need radical treatment anyway. In this procedure, what we need is actually proper staging. So during the ombre resection, if we are able to resect it in one piece, even if we take it out in multiple pieces, the staging part should be fine. So I think the limitation is actually not as big as we think it is. And the truth is that we cannot be really sure intraoperatively whether the patient is having a muscle-invasive disease or a non-muscle invasive bladder cancer. So I always try to do ombre resection, hoping to ensure a complete local resection and hoping the histology comes back to be non-muscle invasive disease. Again, during the procedure, if we excise in one piece, even if we take it out in multiple pieces, I believe the benefit of ensuring complete resection can still be preserved. So in my practice, I try to do the procedure as en bloc as reasonably achievable, and I believe this is the best way to go. Of course, there will be some challenging cases, so I hope to take this opportunity to show you 2 cases which are quite challenging. First one, this is actually a live demonstration in the SIUE grand round, 78-year-old man, BCG intolerant, recurrent high-grade non-muscle invasive bladder cancer. When I put in the endoscope, actually with white light cystoscopy, you can't see major tumors. But once I have switched to the NBI mode, then you will be able to realize actually a large area over the left lateral wall is actually quite diseased. And these are very representative of CIS changes. And because this type of tumor is very flat, it's very soft, it's not big, cell type tumor, so I still try my best to do ombre resection. Of course, in big areas like this one, it will be more difficult, but still, I mean, it's feasible. And because these tumors are flat and soft, even if the surface area is very big, you will still be able to flush the tumor in one piece easily. And as you can see, I'm trying to use the loop to push the tumor up and then excise the bottom part here. And you can see the crossing fibers below. And just to show you how the resection bed looks like, so basically quite a big area. We try to resect down to the muscle layer in every bit of the resection bed. So at the end of the day, pathology came back to be high-grade non-muscle invasive bladder cancer with CIS changes. Very interestingly, the margins came back to be clear, and the patient 1 year down the line is still currently in a disease remission. Second case, big tumor. Initially, when I looked into the cystoscopy report, it's supposed to be a small tumor. But when I went in, I saw that it's actually quite a big one. Sessile tumor over the right posterior lateral wall. I believe it's not possible to do ombre resection. But what I did, I resected top, the exophytic part in a peaceful manner, and then I resect the base with ombre resection. And because it's a lateral wall tumor, there's actually an arterial jerk when excised it. And therefore, what I did here, I reached the margin, the junction between the submucosa and the muscle. You can see, because of a jerk, I tried to do some blunt dissection. I'm able to push, to tear the tumor away from the underlying muscle layer. And interestingly, because the base preserved, the margins again came back to be clear. Luckily, it came back to be non-muscle invasive disease. And again, I believe this procedure really ensured a complete resection in this case. When you're really dealing with big tumors, we may need some special ways to extract the tumor. Morcellator, but it's probably not the best approach because there's, again, the risk of seeding. But you can also use endobags. And the other thing is when you use the modulator scope, the channel is actually quite big. You can actually use laparoscopic instruments to insert through the modulator scope and try to grab the tumor with a good bite and then take it out. And this is what I meant, modulator scope together with laparoscopic instruments. You can insert this instrument through the channel and then have a good bite and then try to take the tumor in one piece. And it's actually quite a good maneuver to adopt. I think in summary, Ombre Resection aims to ensure a complete local resection and to minimize the risk of tumor implantation. I think we have enough evidence and experience to say that it's safe and technically feasible for tumors less than 3 centimeters. For big tumors, it is challenging. There are different methods to facilitate tumor extraction. But I think at the end of the day, even for big tumors, even if we need to take it out in multiple fragments, if we excise it in one piece during the procedure, at least we can ensure a complete resection, which is still very important in the case of non-muscle-invasive disease. But of course, at the end of the day, it's not just about experience. We need high-quality trials to prove its value before it be adopted routinely in a generalized manner. To end my talk, if you're interested in this procedure, I would strongly encourage you to read about this international collaborative consensus statement, which was just published last year in European Urology. Basically, we try to gather the opinion from experts around the world. We try to define what is considered the standard way of doing the procedure, what is the best case selection, how should we document the operation record, how should we assess the specimen, how should we manage the patient after ombre resection, what are the important outcome measures and patients undergoing ombre resection, etc. And we hope this statement will serve as a good reference for people who would like to adopt ombre resection in their clinical practice. And I hope my talk will be able to inspire you that we certainly need to resect the tumor in a better way. And I still believe that a good resection is one of the most important ways to optimize the cancer control in the case of non-muscle invasive bladder cancer. And by this, I would like to thank the organizing committee once again for the invitation, and I hope you have enjoyed the presentation. Thank you very much.
Thank you very much, Jeremy. That was an excellent talk on on-block resection techniques, and it's fascinating to see these newer techniques that are available for tumor resection. I'd like to now introduce our next speaker. It's Kamran Haq. Kamran Haq is a senior urology registrar at the Freeman Hospital in Newcastle, and he's prepared muscle invasive bladder cancer. Thank you.
Hello everyone, my name is Cameron. I'm one of the urology registrars at the Freeman Hospital in Newcastle upon Tyne, and today I'm going to be talking to you about intravesical options for non-muscle invasive bladder cancer. Before we get going, I'd just like to thank the organiser of the course today for inviting me to speak, and also apologise for not being there in person. Fortunately, you guys will be saved my smiling face in the corner of the screen. We're going to get cracking. There's a bit to get through, so apologies if I run on a little bit, but I hope you will find this talk informative and enjoyable, or as enjoyable as intravesical chemotherapy can be. We'll start off by talking about bladder cancer in general. So it's something that as urologists we all encounter regardless of your subspecialty. It's the 11th most common cancer in the UK with around 10,000 cases annually. And as with any cancer, we talk about staging. And within bladder cancer, we talk about muscle invasive and non-muscle invasive disease. This talk pertains to non-muscle invasive disease, which is TA, T1, and CIS. And that's important because actually the majority of patients that we see are going to have non-muscle invasive disease. It comprises 80% of new diagnoses of bladder cancer. And most of these patients, if not all of them, along their patient pathway somewhere will have a form of intravesical therapy, be it either a single installation or a maintenance course. Today we're going to really focus on Mitomycin C and Bcg. This is because this is the thing we use the most in our practice. However, there are other intravesical agents, and we will touch on them briefly for completeness. So today we're going to cover what the options are for intravesical treatments, and with that, how they work. We're going to look at who we're giving them to, and that's mainly going to be based on the guidance issued by the EAU. We're going to talk about why we're giving them, look at the evidence behind the practice, and then also touch on when we give the therapies in terms of timing and schedules for maintenance dosing. Alongside that, we'll discuss when we don't give them, mainly with regards to contraindications. Lastly, I think it's important to think about the practicalities of how we give them. It is something that comes up in exams and something that we will have to do in our practice from time to time. And it's important to understand the logistics for patients as well as prescribers. So to start off, full marks to anyone who can recognize this drug, but this is the chemical formula for Mitomycin C, something we use very often in practice. What is Mitomycin C? Well, it's an anti-tumor antibiotic. Its mechanism is causing cross-linking in bladder tumor cells, which essentially interferes with the synthesis of DNA. It targets tumor cells as they're more metabolically active and therefore more susceptible to the drug. And it's usually administered in a single installation post-TURBT. However, it can be administered as a course in certain situations. What is cross-linking? Well, cross-linking is the process by which strands are formed either between two strands of the DNA helix, that's just referred to as interstrand cross-linking, or between two amino acids on the same strand of the helix. And you can see in the pictorial representation how this can affect DNA replication. Next, we're going to talk about who gets mitomycin. Now, the EU have suggested that we give Mitomycin C in a single installation post-TURBT to patients with tumors presumed to be low risk, or in those who have papillary recurrences detected more than a year post previous TURBT. I think in practice, we're giving mitomycin after TURBT to most patients who have papillary or superficial disease. There is a role for maintenance doses of mitomycin, and the evidence of that is from the Tolle et al. Study, which showed an improvement in recurrence-free survival in intermediate risk disease with repeat installations. Who are we not giving mitomycin to? Well, the Sylvester trial, which we'll touch on again in a later slide, suggested that single installations are not beneficial if the ARTC recurrence score is more than 5 or the recurrence rate is more than 1 per year. I think that's important to understand, but also slightly impractical in terms of everyday practice, because we're not going to work out recurrence risk scores for every single patient. From a practical point of view, if a patient has a solid invasive looking tumor or has large high-grade looking papillary disease, then mitomycin probably isn't going to be the most important aspect of their management. So why are we giving mitomycin? Well, the most quoted meta-analysis is the Sylvester et al. Meta-analysis of 2,200 odd patients, 13 studies looking at single installation post-TURBT. This study looked at mitomycin alongside other intravesical agents such as pirarubicin and epirubicin. For mitomycin, what it showed was a 35% relative risk reduction in recurrence, which translated to a 14% actual risk reduction and a number needed to treat of 7. You can see the effect on recurrence demonstrated on the graph at the bottom of the screen. Why is that important? Well, it's important in the patient group that we're giving mitomycin to, because they are a group of patients who do recur on a regular basis. When we look at TA disease, we can see that 50% of patients will have a recurrence, and T1, 50 to 70%. So it's easy to see why it's important for us to administer therapies that reduce the risk of recurrence in this subgroup of individuals. So we've covered what mitomycin does do. It's also important to cover what it doesn't have an effect on. And the two things that it doesn't affect are time to progression and time to death from bladder cancer. And this is important when you're counseling patients on mitomycin and the reasons for administering the therapy post-TURBT. So when are we going to give mitomycin? Well, usually it's a single installation post-TURBT. The EAU recommends immediate installation, but gives no real specifics on what that means. There is talk about it being preferably given within the first 2 hours, and usually the efficacy is quoted as up to 24 hours, but there's no strong evidence that dictates the optimal time to give mitomycin. When are we not giving it? Well, the major contraindication to mitomycin administration is perforation, which is usually iatrogenic at the time of TURBT. This can lead to significant chronic inflammatory process within the peritoneum if it does leak within to the abdominal cavity, which can result in chronic pelvic pain and severe inflammatory reaction at worst of frozen pelvis. Practically speaking, if there's a suspicion of perforation intraoperatively, then always best to err on the side of caution with regards to mitomycin and not give it. How do we give it? I think it's really important to understand the logistics of giving these drugs. It does come up in exams, but also it does come up in your day-to-day practice. Now, mitomycin is a hazardous substance. It's therefore given in a closed system. And the setting in which it's given depends on which department you work in. Where I work, we give it in our recovery ward, and it's usually the nurses that are administering that. But if you're working in different departments or the nurses on shift don't know how to give it, then usually they'll defer to you. You can see in the picture the constituents of the kit. One is the drug itself. The other is a closed system for administering it. One end attaches to the drug dispenser and one end attaches to the device used for installation. And in between, there's a pressure bag, which you essentially squeeze to transfer the liquid. It's given in 40 milligrams in 40 mils of normal saline, and it stays in the patient for about an hour with them asked to change position to ensure adequate coating of the bladder. If patients don't have a catheter in, you need to give them careful advice. They need to sit down to void. They need to avoid splashing, and they need to avoid getting it on their hands, as it can result in a rash. They also need to put bleach into the bowl for 15 minutes before they flush, as part of the disposal or safe disposal of hazardous substance. Another bit of important patient advice is to avoid sexual intercourse for 24 hours post-treatment. What are the side effects? Well, the side effects include dysuria, frequency, hematuria. With any drug, there's a risk of drug reaction and also rash if it comes into contact with the skin. Usually it's tolerated fairly well. So again, important to warn patients about side effects, but not something that will affect compliance, so to speak. I'm going to talk a little bit on heated mitomycin C. It is something that may come into practice in the future. Heated mitomycin essentially is what it says on the tin, so mitomycin heated to a temperature that is above body temperature, usually between 40 to 44 degrees C, and it's thought to improve the efficacy of the drug in a number of ways, which we'll describe briefly. So it's thought to improve the delivery of the drug, and that's due to increased blood flow to the tumor, local vasodilation, which results in increased cell permeability and therefore better drug penetration. And that's a phenomenon called the enhanced permeability and retention effect, or also known as the EPR. Alongside that, the heat actually creates a more hypoxic environment for tumor cells, which directly leads to tumor cell death or cytotoxicity. There is a degree of chemosensitization. Mitomycin is a drug that's been shown to be more efficacious when it's at higher temperatures and has something called a thermal enhancement ratio of 1.3, which essentially means that the drug is more effective to a tune of 1.3 when heated. Lastly, there's an upregulation of the body's own immune response that's thought to be associated with hypothermic treatment. Has it come into practice yet? Well, not quite. It's been proposed in the neoadjuvant and adjuvant setting. There's no strong evidence at the moment. There is an ongoing study, HIVEC2, which is a phase 2 multicenter RCT comparing heated mitomycin versus standard mitomycin for new or recurrent intermediate risk disease. The schedule is single installation and then 6 weekly installations with the outcome of disease-free survival at 24 months. And I guess we'll see what that comes up with. In terms of the guidance, there's no specific recommendations in EAU. However, it is mentioned as an option or alternative intravesical therapy. So we're going to move on now and talk about BCG. BCG was originally developed as a vaccine against tuberculosis, but showed some efficacy in the treatment of bladder cancer. And I wanted to spend a little bit of time talking about the origins of this. When I first was told that we use essentially a tuberculosis vaccine in bladders, I did wonder how that came about. Was it just a mad scientist experimenting? But in reality, it was this chappie called Alvaro Morales, who I'm sure a lot of you have heard of. And the use of BCG as an anti-tumor therapy dates back to 1929, where autopsy series performed by Pearl at Johns Hopkins noted a lower cancer rate in patients with TB. Following that, BCG was proposed as a treatment for cancers in the 30s, and then was first used as a treatment of leukemia in 1969. With regards to bladder installations, it was first done in guinea pigs and then went on to be trialed in humans, with the seminal paper being Morales' paper in 1976, which looked at 9 patients who were given intravesical BCG with favorable results. And this really has formed the basis of our practice today. So what is it? Well, it's a live attenuated strain of Mycobacterium tuberculosis, and there's 3 strains that we use: Connaught, Oncotyce, and RIVM. We're currently using Oncotyce in our practice, and certainly that's the one that I've seen most in my career to date. How does it work? Well, there's a big blank space to the right because we don't know how it works entirely. And there are a number of proposed theory, and I'm going to go with the most popular to date. So the mechanism that's proposed is that BCG enters cells or infects cells via the fibronectin receptor. It is then internalized into the cell, and within that triggers an immune response regulated by cytokines. Which cytokines? Well, pretty much all of them. So if you're ever asked that in an exam, if you just rattle off a few numbers, I'm sure you'll probably get one of them right. And tumor necrosis factors also thought to be involved. Then follows what I can only surmise as a complex immune cascade, which results in anti-tumor activity, and that's thought to be regulated by T cells, natural killer cells, neutrophils, and macrophages. So we don't know exactly how it works, but this is how we think it works. But certainly, so who are we giving BCG to? Well, really we're giving it to patients who have intermediate, high, or very high-risk tumors. And we'll take a step back a little bit and just define those risk groupings. I'm sure you've all heard of them before. I'm sure you all know them, but it's useful just to recap. So the EAU defines low risk as primary solitary TA disease of less than 3 centimeters with no CIS. High risk is defined as either any T1, any G3, any presence of CIS, or multiple or recurrent large papillary G1 or 2 disease. And really the intermediate risk grouping falls between those two, so any tumor that doesn't fit into those categories will be intermediate risk. At the other end of the spectrum, there's for very high risk, which is G3T1 plus CIS, multiple large G3T1 tumors, or any variant histology that confers a poor prognosis. So within those risk groupings, the intermediate risk tumors, we're giving it to patients who have primary or recurrent tumors, usually for around a year. For the higher risk groupings, we're giving it to people for 1 to 3 years, with 3 years being the preferred practice if they can tolerate it. And there's also a role for BCG in the very high risk grouping with a caveat. So very high risk tumors, usually the patient should be referred or considered for early cystectomy if they are fit for it. If they're precluded from radical cystectomy because of comorbidity, or they have a very strong patient preference for non-surgical management, then you can consider BCG. And the reason that we're giving BCG is that it has effects on progression and recurrence. And when we look at the progression rates of these tumors, intermediate risk 8.5%, high risk 14%, and obviously, as expected, very high risk tumors over 50%. So again, you can see the rationale for wanting to reduce the risk of progression in disease that falls into these three categories. So how much does it reduce progression by? Well, Sylvester, who's popped up a lot in this talk already, looked at 4,800 patients over 24 RCTs, non-muscle invasive disease, and he showed or demonstrated that BCG has a relative risk reduction of progression of 27% and an actual risk reduction of 4%. With the two small caveats that the BCG only showed benefit if given for over a year, and the median follow-up was slightly short at 2.5 years. So it does have a good impact on progression. What about recurrence? Well, Malmstrom et al., another meta-analysis, nearly 3,000 patients, 9 RCTs, compared BCG to mitomycin, and that showed that BCG was superior to mitomycin with a 32% reduction in risk versus mitomycin. Conversely, they also showed that if you give induction BCG without maintenance, you actually see an increase in recurrence, and that's something to bear in mind, especially in patients who perhaps don't tolerate BCG very well. In terms of primary CIS, which is something that we encounter from time to time, another Sylvester meta-analysis essentially showed that BCG was the most superior treatment, with around 75% complete response, 50 at 5 years and 30 at 10 years. When are we going to give BCG? Well, the schedule that most units follow comes from work done by Lahm, and it's called Lahm's regime. The study itself looked at induction and maintenance versus induction alone, showing induction plus maintenance to be beneficial in terms of recurrence-free survival and also marginally in 5-year survival. And the schedule comprises a induction course at 6 weeks post-TURBT, then at 3 months a 3-week course, at 6 months a further 3-week course, and then at 12 months another 3-week course with 6 monthly courses through to a year, through to 3 years, if that is the intended duration of treatment. It's worth saying that a lot of patients don't get to the end of that course. The quoted figure historically was around 16% get to the end of their treatment. However, I think this is a bit higher now, and a lot more are reaching the desired 27 doses. Over the years, people have looked at trying to change different variables within the BCG regime to improve compliance, and they've looked at a number of doses which are shown to be inferior to standard. They've also looked at trying to reduce the length, and certainly in intermediate disease that seems to have been feasible, and the current recommendation for intermediate disease is for 1 year as opposed to 3, but in higher risk disease there starts to be an impact on the rates of recurrence. Looking at doses, there's been a couple of studies looking at 1/3 versus full dose. One suggested no difference in efficacy for intermediate risk grouping, and the other suggested no difference in toxicity but higher recurrence rates. So the evidence is slightly conflicting there. In terms of strain, there's no current evidence that shows any significant difference between the efficacy of the strains. So we talked a little bit about when to give it. We think that we need to think about when we shouldn't be giving BCG, and certainly as opposed to mitomycin, there are a few more to think about. The first is patients who have immunosuppression or are immunocompromised, and within that, patients who have any active hematological malignancy. For obvious reasons, you're giving an attenuated strain of tuberculosis into the bladder, so if patients don't have a good immune system, this can cause or result in systemic absorption. We shouldn't be giving BCG to pregnant people or to breastfeeding people. We also shouldn't be giving BCG, obviously, to patients who have active TB infections. Another consideration is patients who have had absorption of BCG into the bloodstream and at worst results in BCG sepsis. We shouldn't be giving BCG if someone's treatment for systemic BCG has mitomycin. And again, patient advice, seated voiding, and use bleach to clean the toilets afterwards. Usually you try and get patients to increase their fluid intake around installations, as BCG has a higher side effect profile than mitomycin, and it can help with the irritative lower urinary tract symptoms that it can produce. What are the side effects? Well, the side effects can be classed as either local or systemic. A large proportion of patients will experience a degree of local side effects. The most common is lower urinary tract symptoms, but hematuria, prostatitis, epididymolysis are not uncommon. Bladder contracture can happen in a small proportion of patients, which obviously has implication in terms of their bladder function and then the pressures on their upper tracts. Systemic symptoms happen a lot in a lot fewer cases, although the rate is still quoted as around 19%, which is higher than certainly I think of. And the main one is BCGiosis, which is dissemination of BCG into the bloodstream, and at worst, that leading to BCG sepsis. More commonly, patients have a degree of systemic symptoms, fever, malaise, or pyrexia that can be transient. What is BCGiosis? Well, BCGiosis is dissemination of BCG into the bloodstream, and the risk factors for that are really anything that can expose urothelial capillaries to the substance, and that includes TURBT or traumatic catheterization. Usually presents as a pyrexia, and the treatment is isoniazid for 3 months. Rarely, BCGiosis can progress to BCG sepsis or early or late systemic infection, and these patients need management within the MDT setting, escalation and resuscitation depending on whether they're critically ill, alongside anti-TB therapy, which is usually managed in conjunction with either the infectious disease or microbiology teams. The treatment for tuberculosis infection does come up in exams, and I remember it using the mnemonic RIPE, that stands for rifampicin, isoniazid, pyrazinamide, and ethambutol. What do we do if BCG doesn't work? Well, the EAU have outlined a number of categories that describe essentially the failure of BCG treatment. BCG failure is progression to muscle-invasive disease at any point during treatment. Refractory disease is disease essentially of a high-grade nature that recurs at 3-month check, or CIS, which recurs at 3 months and persists post a reinduction or maintenance of BCG. Any high-grade recurrence during maintenance is also classed as refractory disease. Relapsing disease is recurrence of high-grade non-muscle invasive tumor after a completion or initial response of BCG. Unresponsive disease is slightly confusing. It's defined by the EAU, but encompasses essentially all refractory disease and also high-grade papillary recurrence within 6 months of induction and initial maintenance therapy, or CIS within 12 months of, again, induction and maintenance therapy. Intolerance to BCG is simply patients who have side effects precluding completion of treatment. So what do we do in these situations? Well, these patients usually are fairly complex in terms of their oncological characteristics. They should be discussed in a MDT setting as they have disease that is likely to progress. Usually in disease that's refractory, relapsing or unresponsive, patients should be offered radical cystectomy. If they are precluded from cystectomy, or in the circumstance that they have low-grade recurrence or very late recurrence, then re-challenging with BCG is an alternative. Failing the above two strategies, then really the option that's left is bladder preservation strategies, and these can include alternative cytotoxic intravesical maintenance courses, device-assisted installations such as electromotive installation, which uses an electrode to deliver substances into the bladder in what's thought to be a more efficacious manner, intravesical immunotherapy, and also systemic immunotherapy such as pembrolizumab. What are the other options? Well, in terms of single installation, we talked a lot about mitomycin, but other agents include epirubicin and pirarubicin. There's also some evidence looking at gemcitabine showing that's superior to placebo and reducing recurrence risk, although there isn't strong evidence at the moment comparing mitomycin with gemcitabine in terms of oncological outcome and also side effect profile or patient tolerance. With maintenance, you're looking at BCG or heated mitomycin, which we've discussed before. These are the two references just for the single installation of mitomycin and then the gemcitabine as well. So in summary, most of the patient's journey begins with a TURBT, and a TURBT, as long as they don't have invasive looking or solid tumors and we haven't caused a perforation, our patients usually are going to get a single installation of Mitomycin C, which preferably is within 2 hours, but is okay if it's within 24 hours. Now, we understand that there are other agents available for intravesical treatments, and the reason that we're giving mitomycin is because it has a reduction in the relative risk of recurrence. We're going to counsel our patients on side effects, which usually are quite mild with mitomycin. Following that, usually histology will split your patients into risk groupings, and the ones relevant to further intravesical treatments are low, intermediate, and on occasion very high risk groupings. With intermediate and high risk groupings, patients are going to be considered for BCG as long as they don't have any contraindications. The reason we're doing that is because it affects both recurrence and progression. And the way we're going to administer this schedule is for intermediate risk, usually up to a year, and for high risk, usually 3 years, in accordance with Lamb's regime. The side effect profile can be quite taxing for patients. Most will get some local side effects, a rare few will get systemic side effects, and it's important to understand the treatment of those. After BCG treatment, patients, or during BCG treatment, patients will respond in a number of ways, and those who have unresponsive, refractory, relapsing disease or fail BCG treatment have other options, and those include cystectomy, bladder preservation strategies, or in some cases a re-challenge with BCG. So that's all I have to say on the topic. I'm sorry I've run a little bit over on time, and I hope that this was informative. Once again, thank you so much for asking me to speak, and I hope you enjoy the rest of the course.
Thank you very much, Kamran. That was quite an elaborate talk on intravesical options for non-muscle invasive bladder cancer. We will now be going on to the surgical options in non-metastatic muscle invasive bladder cancer. Over the years, we've had a lot of debate on what the appropriate approach will be. We've had open robotic techniques, and we've also had intracorporeal, extracorporeal techniques that have been widely discussed. I'd like to invite our next speaker, Mr. Nikhil Vasudev. He's a consultant urologist and robotic surgeon. He's also the associate medical director at Stevenage Hospital in Leicester. So without further ado, Mr. Vasudev will be speaking on robotic radical cystectomy, which some would argue is the new gold standard. Thank you.
Hello, and thank you very much for the opportunity to present at the iTRUE URO-GRIPP meeting, which is on urology global residents. Very grateful to Bhavan Rai for inviting me to come across to talk, and obviously to Dr. Zasim Hamid. My talk today is on robotic radical cystectomy. It's the new gold standard. I'm going to share with you some of my data, how my practice from an open cystectomist is now purely robotic with an intracorporeal reconstruction angle thrown in, and some work that my research fellows in my lab does based out of the UK and the United States, looking at low pressure robotic cystectomy from the cytokine point of view, and also from the point of view of particulate matter data research, which I'll share with you. Robotic cystectomy is very much here to stay. It's certainly in its what's happening, there's a lot more needs to be done. Because I think that the robotic technology will be in a very strong position to help our patients with bladder cancer. My center is this hospital in Stevenage, which is located above the mountain. We have cash from about 2 million patients. We have an XI system, and an XI system globally, getting a system across imminently. We do about 350 to about 400 cases per year. We also have 2 down here. That's me, that's typically my colleague, and put it in transit as we work with those issues are global. So these things take a week, and we have very during the COVID-19 pandemic, I also am part of the advisory board on behalf of sports and during the pandemic, it's important not just to be with you, it's our robotic program with a lot of centers of universities, patients, COVID-19, or so on, their program, these reported of course.
Apologies, I think we've had some connection issues, so we're going to reload the presentation.
How my practice from an open cystectomist is now purely robotic with intracorporeal reconstruction angle thrown in, and some work that my research fellows in my lab does based out of the United States, looking at low pressure robotic cystectomy from the cytokine point of view, and also from the point of particulate data research, which I'll share with you. Now, robotic cystectomy is pretty much
Apologies, everyone. We've had some difficulty with the connection. We've got Mr. Vasudev here, and he will try and present it live from his side. I think we've got some internet issues at the administrative side. Thank you, Nick.
Thanks, Pavan. Can you hear me?
Yes, Nick, we can hear you.
Okay, perfect. Well, I'll start off live if that's all right, because
Perfect.
it sounded like I was having a massive epileptic fit, but that wasn't the case during the recording, I promise. So, well, good afternoon. My name is Nick Hilvastev, and I'm very grateful to Pavan and to the faculty to invite me to speak on robotic radical cystectomy, the new gold standard. I'm going to be sharing some data as to how, from predominantly being an open cystectomist when I started my career off in 2014 as a consultant, after finishing my fellowship at the City of Hope in LA, and how things have moved on. And I'll share some latest research just to reinforce where we stand with robotic cystectomy. So the entire onus of how robotic cystectomy is evolving in the UK is largely down to patients driving it, patients demanding and asking for it. And I feel that robotic cystectomy from the ablative point of view is important, but also from the point of view of the intracorporeal reconstruction is even more important, because that's where a majority of the complications happen. So my center is the Lister Hospital in Stevenage, which is a part of the East and North Hearts NHS Trust. We are located north of London, and we have a catchment of about 2.6 million. We have two systems in our hospital. We have an XI and an SI with an imminent third system on the way. And we do about 350 to 400 robotic urological procedures per year. I lead the bladder program, and I do about anywhere between 40 to 60 robotic intracorporeal cystectomies per year. We have two Royal College of Surgeons of England fellows. Obviously, Bhavan was one of them who went back to Freeman. And we've had Ashwin Tamankar from Mumbai, and currently we have Arvind Nayak, who is with us. Now, my role during the COVID-19 pandemic, and the reason why I brought this up, was being on the government response team, which I still am a part of, on being an expert advisor on the COVID-19 response. But the reason why I brought this up is that we were able to carry on with our cystectomy program right the way through, and we saw a surge of referrals come through. There was a lot of controversies about aerosol, a lot of controversies about how aerosol and COVID could be an issue, and the evidence was low level, which has fortunately been binned. But I'm going to show you some work that I do up here and in Connecticut with ConMed Surgical to show you some particulate matter research with the context of cystectomy. Now, COVID-19 and cancer has had an impact at the peak of the pandemic. We did see a significant drop in the number of referrals coming through. Obviously, bladder cancer was not hit as much, because if someone has blood in their urine, it's quite an alarming symptom, and patients will come across and seek help. But especially with prostate cancer, the level of referrals did drop. So being a part of the government, we do release commonly in the newspapers in the UK, those of us who lead the response, to tell patients to come forward, because it's not only the UK, but all of you who are on the call from international countries, are aware that we are here to help patients out. So let's just focus now on robotic cystectomy. The fact of the matter lies that patients will bypass non-robotic centers in the UK. And this is translating into an increased demand in robotic systems, new systems being developed and rolled out. But also, this is similar to what happens in India, in Asia, and different countries, where patient demand and patient need will cause you to allow the expansion of a robotic program to take place. And we've seen surge on surge growth with robotic programs both in the UK and obviously in India. So this is a slide of my practice. So essentially, when I started off towards end of 2014 as a consultant, I was predominantly an open cystectomist, but now my entire practice is purely robotic with an intracorporeal angle thrown in. And I do strongly envisage that by Next year, this year I've done 42 cystectomies, all of them with intracorporeal. And I see the reason why this is important to put out is how your practice can transform and how patients can benefit from the technology that you offer with robotic cystectomy. Now, robotic cystectomy has been around since 2000. There's been a lot of talk about it because centers that were offering prostatectomy, nephrectomy, nephrouretrectomy, partial nephrectomies started rolling out their programs to do robotic cystectomy with a pelvic lymph node dissection, be it level 1, 2, 3, we then do a level 2. But the reconstruction was still extracorporeal. And I'm sure, Bhavan will touch upon some of the latest evidence that we've written together. But I don't want to overlap on that. But the main problem still is the complication rate and readmission rate is still high for robotic cystectomy or open cystectomy or LAP, which is in the vicinity of 1 in 4 patients will come back with some issue or the other between 30 days and 90 days. And that's the reason why we are keen to intercept this problem. And I'll show you some data from the IRO clinical trial that I've got ready for this presentation today. So this is my practice. So essentially, this is a robotic neobladder. I haven't done one for the past 2.5 years. My entire program is intracorporeal. Obviously, the risks of an open operation, this doesn't happen in every patient. I appreciate that. But we have to take into context what this presentation is about. Is it the gold standard? And, there are risks involved when you have a patient who has an open operation done, because you certainly handle a lot of bowel. You do end up with the risk of postoperative pain. You end up with the risk of postoperative wound infection. Whereas this patient of mine on day 10 following a robotic intracorporeal reconstruction looks like this. So it's not only about the operating, but it's also the use of adjuncts intraoperatively, such as low pressure surgery, which we do. So I will operate on a pressure between 8 and 10 for my intracorporeal reconstructions. Obviously, I'm not going to overlap with Dhawan on the talk with the evidence, but whatever randomized control trials have been published, as a paper of mine in TAU and Press, has been extracorporeal. And again, a comment that I published early on in March 2019 with Jim Cato and John Kelly, looking at the data from the RAZOR trial, was that the evidence certainly indicated that open cystectomy is less expensive, robotic cystectomy has lesser blood loss and a quicker recovery. But my main question on the RAZOR clinical trial, which is a fantastic study from Vipin Parekh, who I know very well, it's largely down to the fact that all the reconstructions were extracorporeal, and a lot of the surgeons who were included in their data had only done more than, had done about 10 cystectomies. Now, having had done more than 200 intracorporeal reconstructions, I do feel that the learning curve is fairly steep for this technique. And I'm sure Jeremy from Hong Kong, who I know and who I met, and I've been across to Hong Kong to see how they work, will agree that 10 cases is probably not enough to really have a learning curve with an intracorporeal or a robotic cystectomy angle thrown in. So the main criticism is whether an open approach or an extracorporeal approach really negates the benefit of minimally invasive surgery. This is a paper of mine that was published in BJUI early on this year, in which we looked at HES data from NHS England on 12,625 cystectomies. So this was open, lap, and robotic cystectomy. And when you look at the trend, certainly in about 2013, 10% of patients were having their cystectomies performed via the robotic route. And that figure, as it stands right now, is about 50%. So a year-on-year significant growth. And when you look at some of the outcomes, certainly in the context of robotic cystectomy, the length of stay is slightly lower, from 8 days to 11 days. This is, HES data is very honest, accurate data which is put out. And complication rates are also lower. I don't have a sub-analysis on extracorporeal reconstruction versus intra, but that'll be the next paper that we'll put out shortly. Now, the Cochrane review will obviously be covered by Bhavan in his evidence talk, but the main complications which tend to take place, be it in any type of cystectomy that's done, are predominantly urinary tract infections and ileus, because you are anastomoting gut, you're rejoining gut, so a risk of ileus does persist. And this goes back over many years. These are textbooks which have been published in the past, which is the Urological Clinics of North America, in which the complication rates can vary between 19% to 27% with a neobladder versus 1% to 39% with an ileal conduit. But again, when you zone into the complications which take place, these are predominantly gastrointestinal complications and also UTIs. So we want to work on a program that really reduces ileus and reduces UTIs and ensures that patients do not come back. And even if they do have to come back, we need to evaluate and see how we can use new tools such as AI to predict this. And I'll show you some data on this shortly. Now, my robotic cystectomy program starts off with performing the cystectomy first, then a pelvic lymph node dissection, and then a robotic intracorporeal ileal conduit. The technology that is available with the robotic system, this is predominantly intuitive systems, you can really have a lot of precision surgery which takes place right within the pelvis. So this is a 40-year-old patient who had T2, G3 disease with 4 cycles of neoadjuvant chemotherapy. We have about 70% of patients who have neoadjuvant chemotherapy in my network. And you can see that, the precision really allows you to do a thorough pedicle dissection. This patient, 2 years out, is disease-free, is sexually active, and has done really well. Obviously, bladder cancer is a different beast when it comes to oncological outcomes. But certainly, we work towards ensuring that we can really offer patients the best outcomes that we can from a surgical point of view. Length of stay for my ileal conduits intracorporeally is 4 days, and for robotic neobladders is 7 days. So that's the average length of stay that we have. On the right side is a female cystectomy that's been done. Again, we use basic apparatus. Then when we operate, I use the Vesi sealer now when I'm doing a non-nerve sparing cystectomy, which really prevents you from applying excessive clips on the pedicles, which makes the operation fairly slick and quick. And you can obviously use staple guns, which I'll show you shortly. Now, this is the positioning that is adapted with the SI system. So I know in India, a lot of the systems are SI. I've done Thailand's first robotic neobladder 2 years ago in 2019. And the SI system, it has a slight advantage because you do a port and port in which you can, with your side port, which you use for stapling, you can basically detach the robotic arm and put it through. So this is something which I would recommend if you do want to start doing robotic cystectomies. We have the XI system in my center, and I use a robotic stapler. And I'll show you a video on this right now too, in which basically using the robotic stapler in the past 30 consecutive intracorporeal cases that I've done really has a significant advantage. So it reduces the time, and you as a surgeon on the console has got complete control per se on the stapling applicability during surgery. Now, being a preceptor with CMR, we have also developed a 4-arm protocol with the Versius robot for cystectomy, and we've done intracorporeal reconstruction, ileal conduit. We haven't done a neobladder yet, and this protocol has been set up by Phil Childworth, who's a colleague of mine. I was coming across to Pune to operate before the pandemic, but hopefully, October is when we plan to do intracorporeal reconstruction. So what I'm trying to say is that it's not only down to the intuitive robot, be it the SI, the XI system, or the X system. You do also have stronger contenders such as CMR with the Versius robot coming through, which will help you adapt on a 4-arm CMR cystectomy. So it's not only about, the robotic tech, but certainly the integrated table, which we use, especially during intracorporeal neobladders, really does help, in which you do not have to de-dock during surgery. All you need to do is move the patient with the table attached. So this really helps you mobilize your ileum, which you're trying to join up with the urethra for your robotic intracorporeal neobladder. So again, small steps, small technology with a significant benefit to patients to allow you to operate in a better manner. Now, criticism with robotic cystectomy largely used to be the problem with a stricture on the left side due to traction, due to mobilization. But the key is to ensure that you follow the same principles that you normally do in the context of open surgery or laparoscopic surgery by maintaining the main vessels which are coming off the common iliac to the ureter. And you can see that's the ureter coming behind the sigmoid. Now, what I have started doing with my intracorporeal reconstructions, be it in the context of an ileal conduit or ileal neobladder, which is a modified Studer neobladder, is I use ICG, which I think is a real game changer with your vascular anatomy recognition to see what's going on. So this is a standard uretric mobilization that I will do. I think the principles need to be maintained of using short bursts of diathermy to prevent any thermal injury to your ureter. Obviously, my fellows have been trained and I'm very, very pedantic intraoperatively on handling of the ureter intraoperatively. But you can see, just by gentle traction, I don't use loops anymore. By using short bursts of bipolar diathermy, you can very nicely control the feeding vessels which are coming in. So you don't have to open up more vesisealers or excessive clipping, etc. Just by nice control with some pneumoperitoneum being at about 10, you can achieve these steps. So intraoperatively, all patients will have their ureter sent across for a frozen section analysis on the left and the right. And once you come up to the level of the iliacs, you really want to avoid damaging the proximal pedicle coming off the common iliac artery on the left side. While attempting to cross the ureter behind the sigmoid, again, be careful, be gentle. But the reinforcement is, the talk is about robotic cystectomy being the gold standard, but it's largely down to how you operate also. It's not all about the robot. You need to have basic principles that you follow with tissue traction, ensuring that you don't end up damaging tissue because the robot has no haptic feedback. So this is just going to demonstrate to you the intact pedicle coming off the common. And you also want to ensure that there is no kinking of the ureter intraoperatively. Now, ICG is given approximately 2 to 3 minutes before I do the ureteric dissection. But to evaluate the vascularity, you can see with ICG, you can really accurately pick up the vascularity of the ureters intraoperatively. So you do not want to cut into ischemic areas. You can see the proximal points of the ureters are very, very ischemic, but you can see a nice blood supply demonstration on the left and the right ureter before the intracorporeal ileal conduit is what I did in this patient to take place. And again, bowel anatomy recognition is very useful with ICG too. Now, intraoperatively, I do use the robotic staple gun now in the past 30 cases. Again, I just want to demonstrate some steps that we tend to do with the robotic stapler. It has a bit of a learning curve because it has fairly rapid action, rapid movements which can happen. So this is an ileal conduit being constructed, and this is the robotic stapler being used. The advantage of the robotic stapler is that you as a surgeon operating on the console have total control to see what's going on. And you can use a 60 millimeter cartridge or a 45 millimeter cartridge. I prefer a 60 personally because I think you can take bigger bites through it. And these are obviously staple guns which are being used, which is a blue cartridge instead of the white cartridge. White cartridges you can use onto the pedicles. So I use this for my intracorporeal neobladders and my conduits, and I think this has really made the process a little bit quicker. So just some data, which is always very nice to be open and honest. So I compared 100 of my open ileal conduits with the 107 ileal conduits that I've run robotically. My stricture rate is slightly higher on the robotic series. Left-sided strictures are common. But the way I manage these is a nephrectomy in 3 patients, with 3 having an open reimplantation and 1 having a robotic reimplantation. But I haven't got data on ICG because ICG I've only used in 11 patients so far. But so far things look pretty positive and good. Now, it's important not only to talk about robotic cystectomy, it's also important to see how we can improve robotic cystectomy further. So my interest in my research laboratory is to do with the evaluation of ileus using cytokines. This is the paper which is currently available on PubMed, in which we compared pressure of 12 versus 15 in prostates. Now, in prostates, we don't tend to see ileus that commonly. But the reason why I developed this protocol was largely to see if cytokines would be different. And what we found was that gut cytokines, which indicate ischemia, are higher at a higher pressure and lower at a lower pressure. Now, this has also been translated. We've just submitted this to JU Roll. And I'm grateful to John Pedad, my research fellow, who's been working with me on the project, in which we randomized patients on a 1-to-1 randomization from a pressure of 12 to 15. Oncologically, neoadjuvant chemotherapy-wise, T-stage-wise, everything was fairly stable. But if you look down here on the outcomes of patients between 12 versus 15, we found that the risk of ileus was lower at a lower pressure. The length of stay was lower when you had a lower pressure. And certainly the readmission rates were also lower. So early data reinforcing low pressure being the way forward. I don't have cytokine data yet, but I'll be presenting that as a plenary at the AUA next year. Now, the COVID-19 pandemic is amongst us. We had a situation in which we did not know whether we should stop operating or not. A lot of hospitals in our region last year did stop operating. And being on the Trust Executive Board, I was able to liaise with my senior executive team, evaluate what was taking place, and we decided to push on with our robotic cystectomy program. So we developed protocols to allow us to operate. These were using very, very tight apertures with your ports. Again, making sure that there was no leak. I was operating at a pressure of 6 to 8. And using the air seal device is what we managed to achieve as far as safety of patients was concerned. Also, what we used to do was we were closing all the ports, but the last slide indicates the use of a buffalo filter that we're using. But what we found was that in patients that we did about 345 patients through the pandemic, and we had 0% COVID post-surgery at 30 days, again, reconfirming the safety of robotic surgery in the context of the ongoing pandemic. We obviously collaborated and published this in European Urology early on this year, in which we found that the risk of COVID-19 post-operatively in 599 cases was fairly low. Now, I'm just going to spend a few more minutes on particulate matter data research, which my lab at the University of Hertfordshire leads up here, and we collaborate with the US and Connecticut. But the air seal device largely, is basically a gas equilibrium port in which you have different barriers, a different smoke filter per se. So what we did was we set up some basic experiments in which we set up a bladder cavity, and we did a lot of AI work on the ports to see where the flows were through the port. And the setup essentially is a diathermy machine, a TSI, particulate sizer, to capture data on all ports to see the degree of leak. And I'm just going to show you a video of what we do, because we're trying to mimic the instrument moving in and out of the patient intraoperatively. So this is just a video to demonstrate what we tend to do. So you can see down here that I have got an instrument going in and out. This is an accelerator device which allows us to gather intelligence and information on particulate matter leakage intraoperatively, because the controversy is that with an air seal device, if you put an instrument in and take it out, whether you will disseminate gas all of a sudden with the risk of COVID-19 particles being lodged all of a sudden. So this is what we tended to do. And what we found on our experiments that we've conducted very successfully, which is again in press right now, is that the usage of low pressure with a buffalo filter can really clear your entire abdominal cavity in about 3.5 minutes with a clearance of 95% of particles. And again, this is obviously complicated data. I don't have time to present all this today, but we've compared low versus high pressure, again, reinforcing low pressure to be the way forward, which has been seen in the clinical context to improve patient outcomes, but more importantly, from the safety point of view, is also important to consider. So just to conclude with a few more slides. So this is the IROC clinical trial on which I'm a principal investigator with Jim Cato and John Kelly. This is a trial comparing open versus robotic with intracorporeal reconstruction. And we are using a little bit of AI with DreamPath technology intraoperatively for these patients and postoperatively. Essentially, anybody who has a cystectomy has a fitness tracker, which is an Apple Watch, which is a medical Apple Watch, in which you will have tracking take place at different time frame or intervals at 5 weeks, 3 months, 6 months, and 1 year. And what we found is that patients whose fitness kind of drops off at about a month all get readmitted with a complication. So this is the data coming out from AI. So hence we are trying to intercept and ensure that patients who are pretty fit before surgery, who don't probably be as fit after surgery, after major surgery, we're trying to ensure that we work towards a fitness regimen to prevent them from getting less fit so they don't have a complication. So that's where robotic cystectomy is fitting in. We've also looked and compared to see if AI data from your fitness trackers can predict mortality. Absolutely it can, not only in the context of overall survival, but disease-free survival, both can be predicted. And we've also looked to compare the Apple Watch data to your CPET testing preoperatively. And that's something which we're working on the step count to strongly correlate with the CPET variable. So the fitter someone is, the better they do. And that's the way forward. So just to conclude off, the IROC clinical trial will obviously help us understand whether intracorporeal reconstruction is really the way forward. Current evidence for cystectomy supports lower blood loss, lower length of stay with robotic cystectomy. Early functional and oncological outcomes with intracorporeal reconstruction are very, very reassuring. The operating surgeon, without a shadow of a doubt, is a very important factor. So if someone has done 4 cystectomies and someone has done 200 cystectomies, there will be an outcome difference because it's a steep learning curve. But again, all steps have to be followed thoroughly from the oncological point of view, because a positive margin in a cystectomy, be it in the context of open, robotic, or lap, is non-forgiving because patients will develop a disease recurrence. So follow the principles to the hilt with all 3 steps with cystectomy. And again, newer systems coming out, the CMR system coming out, new technology will improve outcomes further with robotic cystectomy, because I feel it's very much in its infancy right now with a tremendous amount of potential to put in, especially when you throw a little bit of AI and integrated technology. So I just want to acknowledge Carol Takastika, who's a friend, colleague, Jeremy from Hong Kong, Pavan Rai, Alex Motri, Mahendra Mandari, Professor Das Gupta, and Tim Lane, my colleague. Thank you very much.
Thank you very much, Nick, for that excellent talk, giving a strong case for robotic radical.
Pavan, I think you're on mute.
Am I on mute? Can you hear me? Giving a very strong case for robotic radical cystectomy. Obviously, there are arguments for open radical cystectomy. We have Gokul Kandaswamy, who's a fellow colleague. He's both an open and robotic surgeon. And the next presentation is looking at the case for open radical cystectomy. And some would argue old is still gold. If I could have Gokul's presentation up, please. And immediately after this would be my presentation summarizing the evidence.
Hi, my name is Gokul Kandaswamy. Many thanks to the organizers for this kind opportunity. I'm going to talk about the role of open radical cystectomy in the present era. I have no specific disclosures. My expertise is in pelvic oncology. We're going to cover quite a bit of things today regarding bladder cancer, cystectomy compared with robotics. We know the conventional indications for cystectomy, which is localized non-metastatic muscle-invasive bladder cancer, and in high-risk non-muscle invasive bladder cancer when BCG has failed. Not sure whether people whether come across the concept of very high-risk non-muscle invasive bladder CA. EAU started to classify this separately a few years ago, and this has evolved over the last few years. A couple of years ago, it used to be anything that is G3, T1 with CIS, with lymphovascular invasion qualified as highest risk or very high risk NMIBC. But as you can see now, even with TA disease, when they have a few other risk factors, then they become the highest risk NMIBC. And they have developed these 3 new additional risk factor criteria. It remains when you have variant histology, prostate urethral CIS, and lymphovascular invasion, they do get upgraded as the highest risk NMIBC. And in this category, upfront cystectomy is preferred rather than sending them for immunotherapy or BCG. Why is that so? We know because with the nomograms and with long-term studies that this cohort of patients have the highest risk of progression, and it is roughly 40 to 50% over a period of 5 to 10 years, which is significantly high, and hence upfront cystectomy is indicated. What's the biology of bladder cancer? It is different from other cancers, as you know, and especially muscle-invasive bladder cancer is not a localized disease to bladder. It has to be treated as a local regional disease, which means you need to have good cancer control, not just by removing bladder, but also lymph nodes. The importance of lymphadenectomy is beyond debate. It's well settled. And a lot of series, good number of patients have shown that even in a muscle-invasive bladder CA, where the disease is confined to the muscle wall alone, you have a 10 to 25% risk of lymph node involvement. And as the T-stage, pathological T-stage increases, the lymph node involvement increases as well. Sorry. So if you do not do lymphadenectomy at all, which is this green line, you can see the significant drop in survival. And in fact, it is worse than people in whom there is actually a positive lymph node, which means by doing lymphadenectomy, you're probably potentially curing a patient with positive lymph node, and you're doing a much worse service by not doing a lymphadenectomy. And also in 2008, the CA database review has shown the importance of survival in lymphadenectomy in improving survival And they even could come up with the number that when you retrieve more than 16 lymph nodes, the survival improvement is better than with other number of lymph nodes retrieved in specimen, and it is now considered as one of the quality measure for your lymphadenectomy. And you can see that the improved survival is sustained even beyond 10, 15 years. The 5-year disease-specific survival, when you compare and look at other cancers, it's significantly worse for bladder. When it is confined to the muscle wall, your 5-year survival is below 80%, and as the T stage increases, it drops below 50 and 40 and so on. On an average, we used to say, if you are counseling somebody for cystectomy with muscle-invasive disease, the prognosis in 5 years from that point is survival is about 50%. If you put these parameters on nomogram, you can see how bladder cancer behaves, even a T1G3 disease, so-called high-risk non-muscle invasive bladder cancer is as bad as somebody with Gleason 10, 12 out of 12 positive course, and with PSA of 75, and with clinically palpable extraprostatic disease. So it is much worse than what many people think. When it comes to surgery, what do you remove? In men, it's fairly standardized for a standard radical cystectomy. In women, way back in 2005, it's described that the anti-urethra should come out along with your specimen, but as you can see, there's no mention of ovaries or fallopian tubes, which is now considered as a part of standard cystectomy, but not urethra anymore. The rationale here is that there is a significant variation in what you should remove as a part of standard cystectomy, and with the era of neobladder and organ preserving, especially for sexual functional outcomes, these things do change. So what we remove depends upon these other parameters as well. But whatever we do, what cystectomy involves is, it is a surgery on multiple system, i.e. urinary tract, genital tract, bowel system, lymphatic system, and the metabolic system. Even in people who are having just a conduit diversion, there is some degree of alteration to the homeostasis, or the metabolic homeostasis. So it is one of the most complex surgeries performed, and hence morbidity is inevitable. There are some standardized quality indicators of how a prostate cancer surgery should be measured, but we don't have any in bladder, probably for the reasons we discussed earlier. But we can develop certain indicators, and any quality indicator should cover broadly all these areas. There's a survival data, the patient-reported outcome measures, or the cancer survivorship data, quality of surgery, complication from surgery, etc., and also how good is your pathological specimen. And there's a special mention about lymph node status, so I put that separately there. Just going into lymphadenectomy a bit more detail, a good standard lymphadenectomy should cover all these areas there. So level 1 lymphadenectomy, or standard lymph node dissection for bladder cancer, should involve external, internal iliac areas with obturator, sort of lymph nodes, area behind the major vessels, which is the fossa of Marseille. Presacral lymph node could be considered as a level 2 by some, but ideally should be part of your level 1 dissection. So this is the minimum lymph node dissection that you're expected to do. And there are higher levels of lymph node dissection described as well to be selected for appropriate patients. For people who giving exams as part of your training, just be mindful that the definition of level 1, level 2 differs between prostate and bladder cancer. Now, why is this area of dissection important? We know 95% of positive lymph nodes will be covered or will be removed if you follow the standard template. Obviously, if you go higher up and do extended node dissection, you will get more nodes in the specimen, and also you will increase the chance of picking up positive lymph nodes when you have higher stage disease. So more the nodes, more the yield. That's quite obvious. What it means is that you're increasing the chance of picking up node positive disease, which means you're clearing micrometastasis as much as possible. And also you're making them eligible for adjuvant chemotherapy when you can pick up node positive disease, which should improve your survival. We know way back, and this is roughly 15, 18 years ago, this was published to say that the commonest landing site is actually along the internal iliacs. And I know from experience that is one of the areas which is commonly missed during dissection. If you look at mapping studies, you can even see lymph nodes quite higher up in a T2 disease. And as the T stage increases, the number of lymph node involvement and the proportion of nodes at higher levels go up as well. Does that mean we do an extended lymphadenectomy as a routine thing? Answer is no, we don't have the evidence yet. But the SWOG study, which is probably due for publication, should be able to answer that when it is out. This study randomizes radical cystectomy patient to standard and the extended lymph node dissection. And then we will have a 3-year disease-free survival data once published. So what are the parameters that makes difference here in lymph node dissection? To me, it is not a pure surgeon's performance, it's a pathologist's performance as well. The reason is that because as surgeons, we can control the area of dissection. So starting from the genitofemoral nerve, which is your lateral extent, clearing all the tissue from there, that's the bone behind, and there are major vessels, and you go behind the vessels and ensure clearance. The fossa of Marseille, obturator fossa, and that is your internal iliac chain, and you go all the way up to the mesorectal fascia, and that ensures a good anatomical clearance in the boundary. Now, what happens after we remove the specimen is completely beyond our control. We know that for the volume of specimen we remove, we expect about 1.5 to 2 lymph node retrieval for each centimeter we retrieve. So you should be able to expect the number of lymph nodes according to the volume of specimen you remove. Do we have to send them in separate packets to increase the yield? That's something that's been discussed. But if you have taken care of the volume and the anatomical boundary, you don't have to worry about presenting them as separate packets as external iliac specimen, internal iliac specimen, obturator specimen, and so on. But a lot happens in the lab after it is sent to the lab. The way the pathologist dissect and retrieve lymph nodes is highly variable. Most of the time it is done by gross inspection and palpation. And we know by changing the way you do it, actually you can increase your lymph node yield. And in fact, even asking pathology assistants to do it, then the consultants themselves also increase their yield. Most of these studies are in colorectal. In fact, this has been extensively studied in colorectal CA rather than bladder CA. So that's one area where urologists could focus on for the future is about these sort of concepts where how to improve lymph node yield. And whether there is any association between high volume centers, the type of surgeons, particular pathologists, and so on and so forth. Next is how good is open and robotic at this point of time? This is the latest, best available evidence, the Cochrane review, which Bhavan did a couple of years ago, published in the database. Only 5 studies eligible for the evaluation, the 5 RCTs, the best of which is the RAZOR trial, which is the highest level of evidence so far. It's not a great number of patients that were eligible for this systematic review. And the most important thing is that all these RCTs report on patients who had extracorporeal diversion or anastomosis. Now, to me, that is quite counterproductive. There's no point spending millions on a kit and not performing an intracorporeal anastomosis. Of course, the IROC is going to address that issue, but until we have that data, we don't have a good quality data at the moment. Even among what we have, we don't see any difference between open and robotic. The main parameters that we adopt to measure as the quality of our surgery. The difference lies in minor complications where robotic fares better, and in transfusion rates. Of course, transfusion is important, but so that's the only area where robotic actually scores over open, the best available evidence as of now. Cost of these 2 treatments, traditionally we used to think robotic is costlier than open, but the problem with all these costing studies is it's so variable between different healthcare setups, so it's very difficult to compare. 2016, Hugh reported from C database that there's a $3,000 to $4,000 increased expenditure on the robotic cystectomy patients, but more than the operative cost, the health economic evaluation suggests that reducing the complication and improving the overall survival is probably the best form of making things cost effective. This is Nick Vasudev group who published this earlier this year. So if you take 2018-19 as a reference year, and if you look at the costs of these 2 treatment options, it's not a huge difference between the 2, and it is the cost of readmission complication actually remains a huge concern. Positioning of the patient between the 2 approaches, I think you could try this for yourself. If you spend 5 minutes in hyperextension yourself, 5 minutes in Trendelenburg, street Trendelenburg, you will know how difficult you will feel after 5-10 minutes. So there are definitely some possible safety issues which is not fully well analyzed or published. Cosmos is other thing that people talk about. The picture on the left is from Campbell Urology, where that's the description of an incision for cystectomy, which I don't completely agree with. Cystectomy is a true pelvic area surgery. You don't need to go beyond the true pelvis for all aspects of surgery, and hence your incision don't have to go all the way up to the umbilicus. I usually say an inch and a half below that level is more than enough. So roughly about a 12 centimeter incision is what we do. That's your ileal conduit procedure, and that's a neobladder procedure, and this incision size is fairly the same. As long as you can get one hand inside the abdomen, that's more than enough. Does robotic cystectomy equals small scar? Definitely not. If you just combine the length or the size of these incisions, and assuming you could need to have a couple of inches of incision to take the specimen out, you're probably looking at the overall length of these scars will be as big as open radical cystectomy. Uretric anastomotic stricture rates is something that's not very well described. There is a paucity of data, but from what we have, we know robotic approach is an independent risk factor. This is from a fairly large scale study published just last year. If you're a novice who is starting to do robotic cystectomy, just because your experience is low, that itself will is an independent risk factor for a stricture rate. And in fact, it's noted to be roughly about 47% in the first year. And in fact, even if you gain some experience, it doesn't get that better that quickly. Readmission rates, there's no difference between open and robotic approach. As mentioned earlier, this is one of the main criteria to reduce costs of surgery, but both fare actually similar. But what's more important is when you look at patients who are getting readmitted, the reasons why they're getting readmitted remains fairly similar. And even the timing when they get readmitted after surgery is also fairly similar. And the proportion of patients getting admitted at different timings remain fairly similar. So there's no big difference between the two approaches. Positive surgical margin, the previous systematic review and meta-analysis before Bhavan's one in 2019 is this 2015 one, which has addressed this issue of positive surgical margin, wherein there is no major difference between the two. Bulk of the improved recovery after cystectomy is actually due to enhanced recovery program. Both robotic cystectomy and the concept of enhanced recovery came at the same time. So the open cystectomy actually also has improved a lot since enhanced recovery is implemented. So when you talk about cystectomy, the importance of enhanced recovery has to be acknowledged. And in fact, much of the robotic cystectomy improvement in outcomes is also attributed to enhanced recovery. 10 years ago, 40% of cystectomies in US were done robotically and 60% were done by open approach. The change is not that significant year on year. And in UK, as of 2018, we are still doing 40% of cystectomies robotically. So bulk of the cystectomies continue to be done by open approach. It really hasn't picked up as the prostate surgeries have picked up. We say roughly 90-95% of prostatectomies are done robotically, but the majority of bladder are done by open approach. And clearly, there should be a reason for this. The length of stay, robotic approach really hasn't made huge change. So there's probably a 3 or 4 day difference between open and robotic, as you can see, but that difference is sustained over that 5-year period. So if it is better treatment, and as surgeons get more and more experience, robotic approach should be able to demonstrate much shorter hospital stay. Again, it clearly hasn't. So how does an individual surgeon's data would look like? This is somebody who has done 400 surgeries in a 10-year time, which is roughly what an average UK cystectomy surgeon would do. In the first few years, you obviously select patients who are less complex, and you can see the only significant difference is in the study is people who are having surgery at the later part of the surgeon's career and experience is he takes up higher complicated cases and patients with poor performance status. Now that actually translates into higher morbidity and in the 90-day morbidity scale, clearly showing that it is the patient parameters which is more relevant than actually surgeon's experience as such. Group of cystectomy surgeons joined together in 2015 and came up with this consensus statement regarding their expected outcomes when they perform whichever approach you adopt for. There are quite a lot of few parameters which are fairly important in cystectomy. The long-term complications, because this is a significant factor in their survival, cost of treatment, etc. And these things are not very well studied. This probably is a case selection bias, which we actually saw in a couple of slides ago with robotic cystectomy. And if you start doing more complex patients, your results probably may just start to match open cystectomy than show any superiority. We don't have strong lobbying and public patient involvement for bladder cancer treatment, so that's an area for us to improve on. And from training aspect of robotic surgeries is highly a fellowship-based training, while open cystectomy can be part of your core training. And in fact, I can say in Wales for the last 5 years from our center, 4 of the SPRs who passed out are pelvic surgeons without doing any fellowships. Finally, what does EAU say is it's not the approach that's key, it is the surgeon's experience and the centralization and institutional volume that determine the outcome rather than whether it's open or robotic. So in a nutshell, bladder CA is actually a much worse disease than many think. And people who actually go for cystectomy, it is probably the only shot they have at cure. Because if that fails, there is no effective treatment following that. So if you consider that, open surgery remains as a gold standard and probably will remain so until we have some very good quality evidence. Robotic approach is good probably for a selected cohort, but it's not ready for the prime time to replace the open approach as of now. Finally, this is not Formula One, where the machine is 95%, and the role of man behind that machine is only 5%. But in cystectomy surgery, it is the surgeon who is more important than the machine itself. Thank you for the opportunity.
Thank you very much, Gokul. That was an excellent presentation and some very strong arguments in favor of open radical cystectomy. The next presentation is a summary of the evidence that I have prepared. Like we all say, the technique is clearly evolving, but the most important thing is the experience and the expertise of the surgeon. If I can ask for my presentation to be played, please. Good afternoon, everybody. I'd like to thank all our previous speakers who've given some excellent talks this session so far. In this presentation, I'll be summarizing some of the key points of the randomized controlled trials that have compared open with robotic-assisted radical cystectomy for advanced bladder malignancy. In any form of trial, when we compare surgical techniques, especially there are a number of outcome measures that are of interest. Clearly, in oncological procedures, oncological outcomes are the most important outcomes that clinicians are interested in. Complication rates, in particular major complication rates, are of interest. Perioperative outcomes such as estimated blood loss, transfusion rates, hospital stay, operative time, analgesia requirements, and return to bowel activity are of interest as well. And the impact that these have on overall quality of life and the cost effectiveness of individual procedures are clearly of interest. There have been 5 randomized controls thus far that have been published comparing open and robotic-assisted radical cystectomy. And all these trials have used some of these outcome measures, and in some trials there have been comprehensive evaluation of all of these outcome measures. I'd like to now present to you some of the key points from some of these trials. Nix et al. Was the first trial that compared open and robotic assisted radical cystectomy in the European Urology. This was a relatively small trial. It was a single center trial and a non-inferiority trial. They had two arms. Arm number one had open radical cystectomy, and arm number two had robotic assisted radical cystectomy. The technique that was used for urinary diversion was an extracorporeal technique. The main outcome measures of interest were perioperative outcomes, although they did use lymph node yield as a method of designing the study and powering the study. They demonstrated that with the robotic approach, the blood loss was lower, analgesia requirements were lower as well. However, robotic approaches were longer operative approaches. Margin rates and lymph node yield were similar between the two techniques. CORAL was a 3-arm study. It was a superiority trial, and it was an expertise-based trial. The 3 arms within the study were an open radical cystectomy arm, a robotic-assisted radical cystectomy arm, and a conventional laparoscopic radical cystectomy arm. In both minimally invasive techniques, the technique for urinary diversion was an extracorporeal approach. The number of studies in each arm was 20. Their primary outcome of interest was complication rates, and their secondary outcomes were perioperative parameters, pathological outcomes, oncological outcomes, and quality of life. They demonstrated that 90-day complication rates were not that dissimilar between open and robotic-assisted radical cystectomy. They also reported that in this trial, the blood loss was lower in the robotic arm, the operative time was longer in the robotic arm. The robotic arm had a shorter hospital stay, earlier return to bowel activity, and the oncological outcomes were similar. Boschner from MSKCC published a superiority trial, which is again an expertise-based trial. This was a larger trial comparing open and robotic-assisted radical cystectomy, and there were around 58 and 60 patients in the 2 arms, respectively. Their main outcome of interest was complication rates. They also published perioperative outcomes and survival outcomes. They had 2 publications in European Urology. The first publication mainly emphasized on complication rates and perioperative outcomes. They demonstrated that both in an intention to treat analysis and a per protocol analysis, the complication rates, both overall and major complication rates, between robotic and open radical cystectomy was similar. The operative time was longer with a robotic approach. The estimated blood loss was lower with a robotic approach. However, the hospital stay in this trial was not that dissimilar between the 2 approaches. They subsequently published their survival outcomes, which included recurrence-free survival, overall survival, and cancer-specific survival, and they reported that there was no difference in survival outcomes. They also were the only trial that reported on cost effectiveness of the 2 approaches. They demonstrated that when a robotic approach was used for a neobladder, it was nearly $4,000 more expensive than an open approach. If a urinary diversion was performed, it was $1,700 more expensive than an open approach. So clearly, the robotics approach was a more expensive approach. No real surprises here. The final 2 trials have been done by the same group, Dip and Parikh's group. And the first trial was really a pilot prospective trial. And the intention behind this trial was to see if it was possible to eventually design and recruit for a larger trial. So they had 2 cohorts again, which was an open and a robotic radical cystectomy cohort. Again, the urinary diversion technique was an extracorporeal approach. And like I said, the primary intention behind this trial was to see if it was possible to recruit for future larger multi-center trials. And the outcome measures that they used were perioperative outcomes, quality of life outcomes, oncological efficacy, and so on and so forth. They demonstrated that the blood loss was likely to be lower with a robotic approach. However, the transfusion rates didn't appear to be that dissimilar. The hospital stay, when median hospital stay was used as a metric, was not that dissimilar. However, the robotic approach had a higher chance of a patient staying less than 5 days. Claving complication rates were similar between the two approaches. Quality of life outcomes were similar again between the open and robotic-assisted radical cystectomy approaches. Interestingly, the return of health quality or health-related quality of life scores to baseline was around 3 months after a radical cystectomy, regardless of what approach was used. This led on to the large RAZOR trial, and this is probably the most comprehensive trial on the subject. This was a multi-center trial. It was a non-inferiority trial. They recruited around 159 patients for the open arm and 153 patients for the robotic-assisted radical cystectomy arm. And their primary outcome interest was recurrence-free survival in 2 years. They looked at every other outcome that we've discussed before, perioperative outcomes, transfusion rates, quality of life outcomes, and other oncological outcomes as well. They demonstrated that the blood loss was lower with a robotic approach. Intraoperative transfusion rates were lower with a robotic approach. Hospital stay, regardless of what metric was used, appeared to be lower with a robotic approach. Operative times, again, were longer with a robotic approach. Complication rates were not that dissimilar between the two approaches. The 2-year progression-free survival, which was a primary outcome, was similar between open and robotic-assisted radical cystectomy. Our group published the Cochrane review that summarized and performed a pooled analysis comparing open and radical cystectomy, which had all 5 trials that I've discussed so far included in the review. This was a paper that I'd first authored, and I'd like to present to you some of the key points in this review. For recurrence-free survival, the pooled analysis suggested that both robotic and open approaches were similar. Major complication rates, minor complication rates were both similar between the open and robotic approach. Transfusion rates were lower with the robotic approach. Hospital stay was lower with the robotic approach. Quality of life outcomes and positive margin rates were similar between a robotic and oncological outcome. One of the criticisms of randomized control trials that have been published so far is that the diversion technique was always an extracorporeal approach. And it remains unclear if an intracorporeal approach is used, whether the complication rates would improve. The IROC study was therefore designed to answer this question, and it is currently recruiting patients. And we hope that the answer to this question is will be established following the maturity of data from this trial. Therefore, in conclusion, based on the evidence that we have available at the moment, there appears to be little difference between open or robotic approach in survival outcomes, recurrence rates, complication rates, both major and minor complication rates, quality of life outcomes, positive margin rates. Robotic-assisted surgery, however, appears to be superior to open radical cystectomy when it comes to estimated blood loss, transfusion rates, and the hospital stay appears to be shorter with a robotic-assisted radical prostatectomy. Thank you very much. I can't now thank myself, so I'll just move on to the next session. So thank you to all our speakers. We've really had an enjoyable session with all the topics so far. I'd like to now request all our speakers to perhaps get involved with the next session. This is I've had 2 cases that I've just organized for some discussion. Can you see my screen?
Yeah.
Yeah. So we'll go through some of the pertinent points that we've discussed so far. And the idea is just to try and apply some of the evidence that we've discussed so far. So the first case is a 64-year-old man who presented with painless visible hematuria. He's a smoker, smoking around 20 cigarettes a day for 40 odd years. He's a relatively fit man with a performance status of 0. He's had his routine bloods done, which includes a full blood count, Usenis or renal function test, and his liver function test, all of which were normal. If I can ask Nikita, this patient, how would you investigate this patient?
Thanks, Bhavan. So I'd see this patient in a one-stop hematuria clinic, and they usually have a urine analysis, microscopy sent off, and if this is negative for infection, we'd proceed to perform a flexible cystoscopy and ultrasound KUB in the unit where I work in. But considering this is a high-risk patient, male gender, older age group, and a heavy smoker, he would stratify as a high-risk candidate. So I would straight away organize a CT urogram proper tract imaging.
Excellent, Nikita. So based on whatever study we look at, we know that patients presenting with visible hematuria have a 20% cancer yield rate, and the majority of these cancers will be bladder cancer, a proportion will be renal and upper tract TCCs. We know that the incidence of upper tract TCCs are low. Gokul, I know you've done some work on diagnostic accuracy and screening. Do you think there's an argument in just doing an ultrasound scan in these group of patients, and only if an ultrasound scan shows an abnormality that we proceed with the CT urogram?
First of all, sorry, I can't start my video. There's some issue with it. I think they're looking into it. So you're only going to hear me, not see me.
That's okay.
So this, there are no guidelines regarding the upper tract screening, especially when you have done one form of initial investigation. So the second line upper tract imaging is something that we don't have proper guidelines about. And we did publish a couple of years ago highlighting all these changes, different sort of recommendations. Within our own data, we didn't find any advantage in doing an CT urogram when your ultrasound was normal. And invariably, all the upper tract tumors that we have picked up, they all showed some sort of abnormality in the ultrasound scan itself. That's what we found. But that's a single center data, of course. The only guideline which does recommend some sort of risk scoring and risk stratification, giving a score for each criteria, say like 2 points for smoking, 2 points for being a male, things like that, is the Dutch Association. They are the only one who give that sort of scoring system. And I think, if I'm not wrong, if your score is above 7, then you recommend a second line upper tract imaging. But the problem with that is that sort of guideline didn't withstand any validation studies. So again, that's a little bit of a debate. There are some medical legal issues in the mix that comes into picture when we discuss this. So what if you miss picking up an upper tract TCC by not doing an imaging, and the cost of that, the implications of that? So that comes into picture in some of the discussions as well.
Yeah, thank you. I think most of us would agree that patients with visible hematuria require being investigated. I agree, has a degree of debate and contention in it. Within our own, we do perform CT urograms in most older patients who present with visible hematuria, especially if they're above 45. So in this patient, we did do a flexible cystoscopy. And the flexible cystoscopy showed a solitary 3 centimeter left lateral wall tumor, and the upper tracts were normal. So the options in this patient, based on the discussions we have, is do the more traditional TURBT or en-bloc techniques, and the jury is out with that. We still don't quite know. But most units will continue to do a TURBT. Do you all agree that if this looks or endoscopically like a superficial tumor, that we must give them intravesical mitomycin C 40 milligrams pretty much as soon as we can? Any debate on that, or would all the panel members agree?
Yeah, that's beyond the debate,
Yeah. Okay, I'm just going to play a video just now, and this is just TURBT that's this is the tumor here, and this patient underwent a TURBT. Based on the Resect trial, what do you think, Nikita, are the quality indicators of good quality TURBT?
I'm not allowed to disclose that yet until we actually give you feedback. But in general, based on my presentation today, you need to try and do a bimanual palpation initially, examine the urethra and the bladder, resect the tumor and ensure you've got muscle in the specimen. Don't fulgurate the base if you haven't got muscle. Take biopsies of any red patches, examine the prosthetic urethra, and consider if you need to take a biopsy based on your findings. And then draw a bladder diagram and ensure that you've labeled the pathology specimen properly. And at the end, as we've already discussed, give intravesical treatment provided you haven't perforated the bladder.
Gokul, I think you developed the QPI indicators, or you had a big role to play in it. And Wales, what would you add to that, or what do you think, Gokul?
Well, I agree with all the points that Nikita just said. When you looking at a quality indicator, kind of looked at it from the evidence point of view, and then also from your local pathways and what factors in those pathways impact on the overall management of these patients, etc. Because one thing we know in bladder cancer is in certain patients where you need radical treatment, if you do not deliver the treatment within 3 months, that is a significant negative impact. So you really need to be on top of it. When you come into the specific factors, the muscle, the presence of muscle in the histology specimen is probably the single most important factor, and that's been proven beyond any doubt in so many studies, and that's a lot of good quality evidence for it. There are few, and the second one is the mitomycin, which we just discussed earlier. So those two are quality indicators that are settled beyond doubt. There are a few other things like completion of resection. Now, what if you don't actually complete a resection? Is it really going to impact on the long-term management? And what if you actually, bladder perforation is something that happens quite commonly, and does that actually really impact on the overall patient pathway and outcome? And then the time for TURBT, from the time you're done your cystoscopy to TURBT, and then your time for your second resection in those who need their second resection. And the indication is to do it within 6 weeks, and many a times that doesn't happen, and when that delay happens, and how much of impact that it carries. So all these things we don't have strong evidence on, but these are all built into in our quality indicators in Wales, so that we should be able to generate some data in the long run regarding this.
Thank you, Gokul. I think one of the earliest proponents of good quality white light TURBT was Param Maria from Scotland, and some of the criteria that he used to define what was a good quality TURBT, as you said, was the presence of Detrusor muscles, which was a surrogate marker of the quality of the TURBT, a complete resection, early intravesical therapy, and also pictorial representation. And it's interesting that with more paper-like technologies within hospitals, that the pictorial representation is becoming increasingly difficult to do. But in any case, these were the criteria that were put in. Do I have Zishan around? Zishan, can you hear? Okay. If Zishan is not around, I'll proceed with the next slide. Now, this gentleman had TURBT. It's come back as a G3PT1 resection. Do I have a Vish as part of the team? Okay, so this patient's had a G3PT1. Gokul, what would be your next approach in this patient?
I'm assuming there is muscle in the specimen, knowing that it's been done by Mr. Dry. So there should be a good quality TURBT with muscle in the specimen. But even if you have muscle in the specimen and it is still G3T1, I would still recommend to have another resection within that 6-week period, as mentioned earlier. It does carry a lot of relevance, and it does impact on the overall management. So I would send this gentleman for another resection.
So the reason why we do a resection is to ensure that there's no residual tumor or any upstaging, any residual tumor. Nick, can you hear me, Nick?
Can you hear me?
Yeah, Nick. So this is a young gentleman who's on re-resection, does not have any residual tumor. He's got a G3PT1 bladder cancer. What do you think the options here are, Nick, and what would you do in your practice?
So what I tend to do, Bhavan, in the re-resection is I do blue light re-resection, especially if someone's got initial T1, G3 disease, because having it done about 400, now this is slightly anecdotal evidence, but we do have the luxury of having blue light TURBTs up here. So we will do a blue light re-resection essentially to make sure that you do not have any additional concomitant risk factors, such as carcinoma in situ present, which can be present. But I think the case is discussed in the MDT as per usual. We look at the quality of the TURBT, etc. And then the options of discussion will be largely between intravesical BCG treatment, a clinical trial. We're just signing up for an interferon alpha 2B clinical trial, which has a similar cytokine release profile in the bladder, versus if the patient's really young and has got a big T1, G3 tumor, then I may also discuss a primary upfront cystectomy with a neobladder or a conduit. But we tend to hold that as a backup option. You know, it's quite amazing that if you go to the US at their tumor boards, how different it is with T1, G3 disease. But I think in the UK, and majority of places will go for BCG, and if they do develop disease, again, not so much in the context of an early superficial recurrence, but if they progress to muscle invasive disease, then the threshold is fairly low to proceed with the cystectomy. How old was this guy, Bhavan?
He was relatively young, Nick. But I think Nick has very nicely summarized what the options are. I'm not going to ask Nick what approach he's going to use. I think I know the answer to that. But we've had a lot of debate on robotic versus open. Is Arjun in the panel at the moment? Arjun, Arjun, in terms of your decision on the diversion as a functional urologist, what would your options be and why?
So, I mean, we've had some really nice presentations on, both robotic and open approaches to these. I think, the paradigm is slowly changing, but from a reconstructive point of view, as we've seen, we've got mainly the neobladder versus the ideal conduit. And, there are a number of factors which need to be taken into consideration. As we've seen, there are risk factors which we need to evaluate. If there's any concomitant CIS, prosthetic urethral involvement, that would preclude you from doing a neobladder. And we know that, disease recurrence in the urethra would be a disaster if you do a neobladder. So you want to make sure absolutely that there's very, very low risk of recurrence there. But also, I think patient factors also need to be carefully considered, because dealing with a neobladder, although it might seem attractive to a lot of patients, especially the younger ones, it's not always as easy as it seems initially. So, most of them obviously don't have normal bladder function, so they end up having to self-catheterize. Neobladders produce a lot of mucus, lots of risk of recurrent infections. So it's something that they need to be carefully counseled about by good surgeons, as well as good, I think, specialist nurses as well, who deal with a lot of these complications. And then obviously ideal conduits come with their own set of complications as well. So again, it's a counseling process, and it's not a one-stop shop. You just come and see these are the options and then say, go away and think about it. It's something that I think needs repeated consultations with the patient and a lot of time, well, not a lot of time, but time to think about what the options are, what the risk factors are, and base the decision on those factors.
Thank you, Arjun. And clearly we can do this with extracorporeal and intracorporeal approaches. And I think what we can say is that it's important to follow the oncological principles, patient factors, and any decision that we eventually take will really depend on the surgeon expertise and what they're comfortable in. I'd like to go to the next case. This is slightly different. This is a 78-year-old man who presents with visible hematuria. He's a smoker, again, a risk factor. He's probably a lot not as fit as the previous gentleman. He's got hypertension, COPD, and he's got a performance status of 1. His bloods are otherwise normal. He has a tumor, which is small, not particularly big, in a large diverticulum in the left lateral wall, just above the left ureteric orifice. Nick, can I just ask you, what are your considerations in this patient who's got a tumor in a diverticulum?
So the patient 78, Pavan, I think you got to evaluate his lower urinary tract symptoms in detail. I routinely will get a 3 Tesla contrast enhanced MRI done. And prior to embarking on the option of a possible robotic diverticulectomy with a reimplantation, also get a CT urogram done to look at the course of the ureter in the context if it sits proximal or close to the diverticulum. So I've just published on 10 of these, which is available online, again, in Current Opinions. But I think you have to be a little bit cautious not to over-treat a 78-year-old patient who has a tumor confined to a diverticulum with the anatomy of where it is. Considerations as a reimplantation, proper imaging have to be considered before. But I will do a cystoscopy and biopsy in and around the base of the diverticulum, not only before surgery, but intraoperatively too, with a frozen section backup in preparation for a robotic diverticulectomy with a plus-minus reimplantation, if it is oncologically safe to do so. I think an important consideration in these patients is that you have to counsel them that they will require adjuvant intravesical treatment depending on the pathology of what is being removed. So if they have high-grade disease in the diverticulum, which is superficial, they may require Bcg or Mitomycin C, but also a fairly interesting concept which has been floated in Belgium, and I've seen 2 of these being done, is essentially to do with bladder brachytherapy, in which you can remove that area and basically put some brachytherapy probes and irradiate it locally. But obviously your center must be in a position to offer brachytherapy too. So there are plenty of options, but bladder preservation is safe with regular follow-up in these patients, Bhavan. That's what I would say.
Thank you very much. I think what I've summarized is that in the early evaluation, endoscopically, the location of the diverticulum is quite important, particularly its relationship to the ureteric orifice. We must also be sure when we make our decisions that all the tumors confined within the diverticulum and what the status of the rest of the bladder is, if they've got disease elsewhere. And you may want to consider PDD-assisted cystoscopy, or in the absence of that technology, you could consider random biopsies as well. And as Nick has just suggested, an MRI may be helpful in local staging. Just 1 minute, let me get my screen tomorrow. So this was how the tumor looked like in the diverticulum. It was here, fairly large diverticulum and quite close to the left ureteric orifice. And we did some biopsies. This was a G3PT1 TCC. And as Nick has suggested, there are a few options. Radical cystectomy is an option, partial cystectomy is an option, intravesical BCG an option, and radiotherapy maybe with evolving technologies where technology. As Nick has suggested, I think this really depends on patient factors. There's a lot to be taken into consideration before a final decision is made. And if a partial cystectomy is considered, particularly the ureteric orifice is close to the diverticulum, there is a possibility of ureteric reimplantation, and that being the case, you do have concerns with reflux and as a consequence. But this is one of those cases which requires close and careful consultation with the patient. This is a shared care decision process, and I don't think there's any form of convincing evidence to suggest one is better than the other. Would the rest of the panel agree with that?
Bhavan, my only other tip, if you do want to start embarking on these tumors, you could see on your CT how close the ureter is on the back of the diverticulum. So you probably will need to reimplant the ureter on the left side. Is counseling these patients for the risk of strictures, etc., in the long term, medical legally, post reimplantation, which is something we need to consider, because the kidney may not function as well, especially if you do a reimplant lower down. So it was just something small which I wanted to reinforce.
Perfect. Gokul, did you want to comment on this as well?
I agree with what Nick is saying regarding role of partial cystectomy for a tumor within the diverticulum. Now, if it is PTA, I would probably be comfortable with it. When it is PT1 within a diverticulum, I would probably be more comfortable with offering cystectomy. Of course, there are all the other parameters, patient consideration, discussion with patient, everything comes into picture. But just purely from oncological perspective, I think a cystectomy would probably what most MDTs would be comfortable with as well, just because it's a T1 disease within a diverticulum. And in this particular one, if you look at the size of the tumor and in the CT, it's fairly a large tumor. And you could probably use some nomograms here, and you probably will edge towards calling it as a highest risk bladder tumor, non-muscle invasive disease. So yeah, that's another way of looking at it.
Yeah, excellent.